Good evening, doctors. I Shumon on behalf of Shield Healthcare, welcoming you all in this discussion on updates in gynecological cancers organized by the Patna Obstetrics and Gynecological Society in association with Gynecologic Oncology Committee of FOXI. So it's my honor to introduce our today's chief guest and Dr. Supriya Jaswal, Madam. Madam is the Secretary, Patna Obstetrics and Gynecology Society, and the Joint Coordinator, Adolescent Health Committee, FOXI. And Dr. Megha Mohan, Madam. Madam is the Joint Secretary, Patna Obstetrics and Gynecological Society, and Secretary, Patna Menopause Society. So with this short introduction, I hand over the session to Dr. Supriya, Madam, for further talking. Thank you very much.
Thank you, Mr. Suman. So today I'm delighted to bring greetings to all of you from Team Patna OBGY Society. Pranam to all my gurus and mentors and all esteemed faculty members. Today we are here on this virtual platform to update ourselves on gynecological cancers that is really very devastating. Let us hear from the experts in this field and take home with us the clarity, the consensus, and the practice points. Let us start with a very powerful theme video of FOXI by our President Dr. Shanta Kumari Madam. May we have the theme video?
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOXI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOXI's commitment towards women's healthcare. FOXI for all, always.
FOXI for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dheera to stop violence against women. FOXI for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme FOXI for all always and Dheera Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman. Swasth Mahila.
Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dheera, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy, and also especially support her campaign, Dheera, Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of Foxy, declare my commitment towards women's health and safety.
So, thank you, madam, for the Dheera and the vow say no to violence against women and Foxy for all, the strong theme of Foxy this year. Thanks to our President Foxy, Dr. Shanta Kumari, madam. Live life to the fullest and focus on the positive. Keep looking up with dignity, says our dear President, Patna OBGYN Society, Dr. Vinita Singh. Vinita Singh, madam, she is Associate Professor in Department of OBGYN and MCH Patna. She is consultant at Care Hospital and IVF Center. She has held many positions in Foxy ICOG Governing Council, YTP Committee Chairperson Foxy, Joint Secretary, Clinical Secretary, and all the other posts of Patna OBGYN Society. She has been the member of Safe Motherhood Committee, Quiz Committee, Practical Obstetric Committee, Foxy, Business Secretary of Patna Journal of Medicine, E-Zone Coordinator, MTP Committee, Foxy. She had been a great organizer, being the organizing secretary of Nikon 2019, invited faculty in so many workshops at FIGO Rio, participated in FIGO Vancouver, organizing secretary of BoxCon 2016, invited faculty in multiple national and local conferences. She has been edited Foxy ICOG campus on PCOD, been the awarded as MG Mishra Award in 2004 and George Mahoney Award in 2012. With these words, dear Vinita Di, I request you to give the welcome address.
Thank you, Supriya, for your nice words. A very good evening and warm greetings in today's virtual webinar. And the topic is Update in Gynecological Cancer, which has been organized by Patna Obstetric and Gynecological Society in association with Gyne-Oncology Committee, Foxy. As chief guest, I would like to welcome a very giant personality who has achieved a greater height and holding the post of Chairperson ICOG Foxy, Dr. Uday Thanewala. I welcome you, sir, and at the same time, I am thankful for accepting my invitation to be the chief guest. I welcome you, sir. Dr. Archana Verma, Vice President, North Zone Foxy, friend of mine, multi-talented, full of energy and enthusiasm, and as well, very active, ever smiling, is today's guest of honor. I welcome you, dear friend, from core of my heart. I welcome Dr. Priya Ganesh Kumar, who is chairperson of Gyne-Oncology Committee, Foxy. Here, I would like to acknowledge her effort and her hard work to organize today's webinar. I welcome Dr. Vinuta Thomas, who is Assistant Professor in Department of Gyne-Oncology, CMC Vellore, and Dr. Bendya Gupta as guest speaker. I also welcome all my chairpersons, Dr. Abha Rani Sinha, Professor and Head Obstetric and Gynecological Department, SKMCS Muzaffarpur, and she is past chairperson, Quiz Committee, Foxy. Dr. Rita Sinha, ex-professor Obstetric and Gynecological Department, NMCH. Dr. Renu Rohatgi, who is at present Professor and Head of our Department, Obs and Gynae, NMCH. Dr. Rekha Jha, who is President, Bhagalpur Obs and Gynae Society. Dr. Sangeeta Pankaj, and Dr. Vinita Trivedi from Mahavir Cancer Sansthan for accepting my invitation to be the chairperson of various scientific program. I welcome all esteemed panelists, Dr. Sundri, Dr. Urvashi, Dr. Nikhil Kamath, Dr. Rajesh Goswami, Dr. Kusum, and Dr. Puneet. I also welcome all my seniors, patrons of my society, especially Pramila Madam, Dr. Manjugita Mishra Madam, if she has joined, and all the seniors who is present in this program.
Dr. Kusum, Madam.
Kusum Madam, yeah. Without effort of all office bearer of Patna Obstetric and Gynecological Society, we will be unable to organize any program. So I would like to welcome all my office bearer, Dr. Pragya, Dr. Supriya, Secretary POGS, Dr. Nibha Mohan, who is also convening today's program, and all executive committee members who is participating today's program. And last, I would like to welcome all my friends, juniors, and all participants, and at last Shield Connect personnel for sponsoring today's program. So thank you very much.
Thank you very much, Vinita Di. Now moving ahead, I would request for lighting of the lamp once. So lighting, let us invoke blessings of Lord Ganesha and start the event with lighting of the lamp to dispel the darkness of ignorance. I request the chief guest of today's webinar, Dr. Uday Thanawala sir, to light the lamp and inaugurate the CME. I request the other dignitaries to kindly join in the virtual lighting of the lamp. May we have the lighting the lamp.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Thank you, dear dignitaries. Now, a very helpful person, a quick responder, a great sense of responsibility. He is always there to help all of us, be it for awarding ICOG credit points or for agreeing to come to our webinars. Thank you, respected sir, for being so humble and always helpful to all of us, to all the Foxians. Sir Uday Thanawala, he is the chief guest of today's program. He is consultant obstetrician and gynecologist at Navi Mumbai. He is chairman, Indian College of Obstetrics and Gynecology, vice president Federation of Foxy in 2015, then treasurer PCO Society of India, chairperson Medical Disorders of Pregnancy Committee of Foxy in 2006 to 8, founder secretary and past president of Navi Mumbai Obstetrics and Gynecological Society, joint secretary Foxy 2005. He had been the recipient of gold medal in FCPS exams, Sir GM Masani prizes for best research paper in 1981-82, Dr. D.K. Datta award for best journal publication in Foxy 2005, ultrasonography, maternal medicine, fetal medicine, high risk pregnancy. Sir has so many accolades to his credit, sir. With these words, I welcome you and I request you to kindly bless the webinar.
Thank you so much, Supriya. Thank you very much for inviting me to this great webinar. The topics are exceedingly important and very well thought of. The whole program is so well thought of. I was very impressed by the whole thing. And of course, Patna is one society which I would have actually loved to visit physically because I have been there when Dr. Manju Geeta Mishra had invited us, I think, for a labor workshop. I mean, what, 15, 20 years back. And then we've been going, I've been there thrice, 3 or 4 times, and I really enjoy all the dal bati and stuff. So anyway, so hopefully we'll see you in person soon. And I see so many of my friends and colleagues here. Archana is here, Archana Verma is here, Priya Ganesh Kumar is here, Dr. Vinita is here. Thank you, Vinita, for being there. And Dr. Kusum Kapoor. Namaskar, madam. आपको देख के बहुत अच्छा लगा. So, and of course, Abharani Sinha, she's one of our very important governing council members of ICOG. So ICOG is bringing you its annual conference this year, which is going to be a physical event in Navi Mumbai, Vashi. So if I'm just allowed to share my screen, I'll show you the brochure. This is what it is. And we have called this conference Googly because we are changing the format of the conference. We thought, let's not have lectures at all. So we are not going to have lectures. We are just going to have 7 experts on the stage, and we are going to have, they'll be the batsmen who will be facing whatever googlies the audience throws at them. So, whatever questions the audience have, whatever clarifications you want, that all will be thrown at them. And this conference is going to be held at the DY Patil campus in Navi Mumbai. And we are actually going to play a physical cricket match. So those of you who are interested in playing cricket, please do come for that also. But otherwise, the first day we are going to play on the Gynac pitch, which we have a very interesting lecture, which those who have joined in today and are interested in the Gynac Onco, it is a lecture, is what is the role of endoscopy today in Gynac Onco? And that has been taken by none other than Dr. Patambekar, and we have people like Nirja and others who are chairing the session, who will discuss for half an hour what actually is the place of endoscopy today. It has a huge role to play, endoscopy, but that doesn't mean everything has to be done by endoscopy. Plus, the whole importance of endoscopy in gynec oncology will be brought in. Plus, on gynecology, Priya is here. She's one of our people who is bringing you a workshop, which will be there on Friday morning on the Gynac Onco. And the whole thing is preventing the preventable, that is mainly focused on cervical cancer in the morning on Friday. And then we have the conference on Saturday and Sunday. So please just look it up. It's going to be on the website by tomorrow or day after, the tentative program, and the final program will be ready within a week or so. And I invite you all to Navi Mumbai to join in this ICOG annual conference. And I hope you will enjoy this, because it's a different sort of format. And I hope it is successful, because I really can't say how it will be. So Archan has also agreed to come to this conference. So people are liking the idea. So enough of lectures. Let's just discuss and clarify all the doubts. That's the whole idea. So hope to see you all over there. And with that, please carry on with this wonderful webinar which we have arranged. Supriya, thank you very, very much, Supriya, Dr. Vinita, Dr. Kusum Kapoor, and all the rest. Dr. Pramila Modi has joined now. Namaskar, madam. So it's really, I think it's high time we now, go physical. But, today I read in the papers that there's another 4th wave coming. So I really don't know what's going to happen. So, but let's hope April is free of COVID and we all can come together. So welcome you all, and thank you all very much for having me here. And please carry on with this webinar. Thank you, Supriya. Good effort. All the best to you.
Thank you very much. Thank you, sir.
So, sir, I and Dr. Vinita Singh, President and Secretary, we invite you to physically also to Patna, sir. As you said, we would have loved to have a physical meeting here with everyone. Thank you. Thank you, sir. Thank you for your wonderful words.
Looking forward, Dr. Uday, for this ICOG, wonderful webinar. We are all waiting for this physical conference now, rather.
Yes.
Thank you.
And Priya has a huge responsibility, because she's managing the whole workshop with Sarita on the Gynac Onco subject. And we did this, ICOG did this weekend courses on Gynac Onco, where Priya was so much involved. Priya, Dr. Nirja, and the rest had put, Maheshwari and all, they had put up we had 7 or 8 modules running on weekends only on Gynac Onco, because I felt, when I took over, I felt Gynac Onco is one field which the regular gynecologist is not really too much aware about, and they would love to sit and update their knowledge, and online is probably the way to do it. So we had this first session of weekend online courses of ICOG on Gynac Onco. We had 7 other subjects, but Gynac Onco was one of them, because I felt it's very important that every gynecologist today in his or her practice should know what are the updates. Everything is changing so fast. What is the treatment modalities and what to offer to the patient. And that is what Foxy and ICOG is all about, to update your knowledge so that you give the best to your patients. So ultimately the patients benefit. Thank you very much.
Uday, can you remember that we were thinking how many candidates will be joining, and we had overflow of candidates, and 33 candidates in one batch.
Yeah, 3 days before the thing started, we had only 4 or 5 people who had joined in that. Shall we do it? Shall we not do it? And by the time we started it on Saturday afternoon, we had, I think, 38 participants. and who had paid money to get into and listen to this course. And the WhatsApp groups are still active, with people acting. So I think Priya, we should do it again, and we will talk about that.
We will, yes, definitely.
Call.
Yes.
Yeah.
Thank you
so much. Thank you so much, Supriya, for letting me give inputs about ICOG.
Thank you, sir. Thank you. And all our Patna Society people are there. Our seniors, Dr. Alka Pandey, madam, Dr. Kusum Gopal Kapoor, madam. They are all joined here to hear to this oncology webinar. So everybody is here and they are very happy about it. Thank you, sir. So a generous heart, kind speech, and compassion are the things which renew humanity, friendship, and connectivity. This is how a very humble, down-to-earth person is a guest of honor, Vice President Foxy, Dr. Archana Verma, madam. She is passionate about creating awareness on women's health. She's Vice President Foxy at present 2021, Founder President of West UP, ISOPAP chapter, advisor to UP COG, organizing chairperson UP COG.
Kam se kam, CV to kam se kam hi
हाँ. And she has got many accolades, and overall she's a very good friend of our Patna Society, Dr. Vinita Singh, our president, then Dr. Alka Pandey, everybody. She's very friendly to all of us. With these words, I request you to bless us, Archana ma'am.
Thank you. First of all, my respected Dr. Uday Thanawala sir, very good evening and my namaskar to you. And really, it's a proud privilege to be both as a VP in charge of Dr. Priya's Oncology Committee and guest of honor today. Supriya, you said I am very friendly to Vinita. Yes, she is my soul sister actually. Not soul sister, she's a real sister. And thoda Kumbh ke mele mein she went to Patna and I am in NCR. So no need to say the blessings, but definitely I will say a few words. And it's really a proud privilege to be here. And many thanks to my friend Vinita and Supriya, and I really welcome all the speakers also, and all respected Dr. Manju Geeta Mishra, Dr. Abhadi, and Dr. Alka Pandey, Dr. Rita Sinha ji, Rekha Jha, Dr. Reenu, Dr. Kusum, and I always say Dr. Pramila Modi ji, because she is a mother of Dr. Charu Modi. So Charu is again quite one of my friend. I always say Modi ji aage to baat hi kya hai. So then because over the years, I am storing wonderful memories of Patna, and I appreciate the tirelessly working Patna team, especially my sweet Vinita Singh, who not only a very beautiful person with a beautiful heart, and when I was nothing, I was just moving around here and there, then at that time also she was taking very good care, like somebody very close and very senior person takes. When I came to Patna, it was only because of Vinita. And since the ancient days, I must say, like the days of Patliputra, this Patna has been always a teaching institution, teaching place where all over the world people used to come. And I am very small person in that way. But I really congratulate the August fraternity together today. And they are also from all over India. Let all enjoy scientific academic extravaganza today. And one thing I want to say that today's topic of this endometrial carcinoma, this topic I really like because it was my thesis topic. And it was one of the unique thesis topic ever given to a student. And it was, unbelievable. You will see it was spectrophotometric chemical estimation of DNA and RNA in comparing histopathology in diagnosing endometrial hyperplasia going to endometrial carcinoma. And it was one of the really hot topic, and everybody used to say, "Are kya ye topic hai? How can it be there?" So, but at that time also, and this also, though it was really a research topic, but it was one of the best time I really liked doing this work. because every day I was going to some department for doing this spectrophotometry, using that, and used to see all the how the color of this DNA and RNA keeps changing when this level of endometrial hypoplasia was increasing. And this diagnosis of endometrial carcinoma is something to be taken care, though it is not very common, but we gynecologists must keep it in mind, especially in all the patient of obesity, nulliparity, and this sometimes taking too much of only estrogen in this postmenopausal time. And they are the, and why for diagnosis, simple thing is this endometrial aspiration and this TVS, doing TVS, and staging of endometrial carcinoma, we all know, is one of the very important thing to manage. And genomic subcategorization is also something very important. And this adnexal mass, and this topic will, I think, is taken by Dr. Vinodha Thomas, and I'm going to listen to her. And Bindya Gupta, she is again very she's a daughter of my very close friend and Didi, and she'll be taking adnexal mass and investigation and management. It is always a great clinical dilemma, what to do and what not to do. And the cervical cancer, yes, cervical cancer is a very important, and Dr. Priya is doing it in a very big way. I'm very proud of her. And because yes, we all gynecologists first of all should get vaccinated ourselves, our kids, and then only we'll have more experience, and we will be able to open the windows for all, and we will be able to counsel all the patients and their daughters for vaccination, because this is something very important to achieve anything. And this is something very easy, it's not very difficult. So I appeal to all to promote vaccination, promote screening, and take care. Thank you very much.
Thank you, ma'am, for throwing light on all the subjects everywhere. So thank you very much for your beautiful words. So now moving
on. Let me thank Archana.
1 minute, please, and all my good wishes to especially all the contestants, especially my friend Dr. Supriya.
Thank you, ma'am.
Thank you, Archana. Your words really touched my heart, Archana. So it's really looking, but I'm feeling so delighted to see you, though on virtual platform. Looking forward to see you physically, my dear friend. But really, thank you very much, Archana. Thank you.
I can only say, when I met Vinita for the first time, I was looking at her. She's a gynecologist, such a beautiful person. Thank you.
Thank you.
What a beautiful person, Dr. Renu Rohadgi, sitting just.
Oh, Dr. Renu.
Thank you very much, madam. So, striving for excellence feels wonderful because you are trying your very best. This is very true of our chairperson, Gynecological Oncology Committee, FOXY, Dr. Priya Ganesh Kumar. She had done her mentorship and training at WHO IARC colposcopy and cytology course trainer for India, FOXY colposcopy course conductor, official master trainer for cancer prevention under NCD, Ayushman Bharat project, Government of India for State Government of MP. And then she has many publications to her credit, to name a few: colposcopy in practical gynecology, author of Atlas of Colposcopy and Cytologic. Then she has got many awards to her credit, like Thane Gaurav Mayer Award, National Award, Zee Hindustan's Swasthya Award for exemplary work in the field of preventive oncology by Union Minister JP Nadda ji. Then IMA Excellence Award and many more. Wonder Foxian Award. Her key positions she has held: ex-HOD Preventive Oncology Department, CR Vadia TMC. Then member of core team invited by President of Malawi, East Africa for MMR reduction project. So organizing secretary, National FOXY, RCOG Preventive Oncology Conference at Goa, Secretary General TOGS, with so many accolades. Madam Priya Ganesh Kumar, she's doing wonderful work. I invite you to say a few words.
Thank you very much. At the outset, these are the blessings from my office, whereas my Shanta madam, let me tell you, President Shanta madam has been really, truly encouraging all our people to, go ahead, do work, and she's been promoting us. And Madhuri Patel madam has been so generous. Anytime you give her a call and she is always there for you. So we feel protected. And my sweet Vice President madam, Dr. Archana madam, she's always there smiling behind me. Whatever you want to do, Priya, I am there for you. So what I am blessed to have such a wonderful team. And there I have my dear friend, Dr. Uday Thanawalla, as ICOG chair. इससे और ज्यादा क्या चाहिए? What do I have to expect as a chairperson? So मेरी पांचों उंगलियां घी में हैं, something which I feel. And yes, Patna Society, Dr. Vinita, as what Dr. Archana said, I have been also, awing you for your beauty. So whatever I've seen you before, but now, till now also. So all that thing, and Patna has specifically with so many stalwarts. I mean, so many stalwarts, so many teachers in the organization, in the Patna. So we have always looked forward. Patna's, I've seen these webinars which you have been doing. Each webinar is a benchmark on its own. So when Supriya approached me that, Priya, we want one Gynae Onco update conference, I was more than happy. In fact, I didn't have time, but I had to squeeze this time and get it done. So thank you very much, Dr. Vinita, Dr. Supriya, and all my seniors. Pranam yahin se. And yes, I wish this conference grand success. And more so, all the faculties, ek hi call pe everyone were ready. So that's biggest, blessings for me that all the faculties from national, ek baat se, ek phone call se, they are ready to come. And thank you very much for this. Yes, we can go ahead. Thank you very much, Vinita.
Thank you, madam. Thank you. So we are over with this very interactive and nice inaugural session. Now we over to scientific session, over to Dr. Nibha Mohan, Joint Secretary of Patna OBGY Society, for further proceedings. Thank you.
Thank you so much, Supriya. At the outset, I want to thank President POGS, Dr. Vinita, and Secretary Dr. Supriya Jaswal for this opportunity. Respected seniors of our society, POGS, and eminent Foxians and dear friends. As you all know, today's webinar by POGS is along with Gynecological Oncology Committee of Foxy. The theme being Update Gynecological Cancer. So we are going to have very important sessions, as we are aware that we cannot stop cancer from happening, but it's very important to recognize the risk factors and making patients aware about it. And our duty to recognize cancer in early stage and treat it at the early stage, because there is drastic difference in morbidity and longevity of the patients if treated in early stage than in the late stage. So today we have got the brilliant opportunity to refresh our knowledge regarding cervical, endometrial, and ovarian cancer. We have two sessions on this theme and a very interesting panel discussion after the sessions. And I must say that we have got 2 ICOG points as well. Whoever is attending will get 2 ICOG points, and requesting all the delegates to put their queries at the chat box so that they will get answered by the speakers simultaneously. So starting with the first session, recognizing endometrial cancer in primary care. What are the red flags and referrals? The speaker is Dr. Vinota Thomas from CMC Vellore. She's a gynae oncologist. To start the session, may I request chairpersons to come on the dais. First, I wish to invite Madam Dr. Renu Rohatgi. We call her Beauty with the Brain. So smiling her picture is also. To introduce Dr. Renu Rohatgi, Madam is Professor and Head of the Department of Obs and Gynae, Nalanda Medical College and Hospital. And this is President Patna Menopause Society at present, and Chairperson Quiz Committee of Patna Obs and Gynae Society. She is examiner of postgraduate and undergraduate students as well. She has published many papers in national journals, and she's guide to PhD students of Aryabhat Knowledge University, Patna, Bihar. So welcome, Dr. Renu Rohatgi, Madam. Next, I wish to invite as a chairperson Dr. Rekha Jha, who's the president Bhagalpur Ops and Gynae Society. And she is very active in Bhagalpur Ops and Gynae Society and IMA and Indian Menopause Society as well. She is patron Jeevan Jagriti Society Bhagalpur and Chief Health Officer International Human Rights and Anti-Corruption Bureau India. So welcome Dr. Rekha Jha Madam. Next, I wish to invite Dr. Sangeeta Pankaj. She's a very active member of our society, and I must say that she's a very helping member to she has helped us a lot many times to have an event in her institute. To introduce her, she is a chairperson of Gyno-Oncology Committee, POGS, and organizing secretary, AGOI Bihar chapter. And she is winner of Saraswati Arora Best Poster Award and Dr. CS Dawn Prize as well. She has been awarded. She is reviewer in many journals, national and international journals, and she has been trained in colposcopy, gynecological oncology, and endoscopy as well. She has presented many papers in national conferences, and she has attended and managed many workshops at different level. So welcome, Dr. Sangeeta. Over to all the chairpersons to start the session. At the beginning, may I request Dr. Renu Rohatgi to invite and introduce the speaker, please. So over to Dr. Renu Rohatgi, madam.
Good evening, everyone. At the outset, I must thank the organizers for giving me the opportunity to chair such an important session on endometrial cancer. We all know that early diagnosis of all gynecological malignancies improves the patient's outcome and survival. The primary care practitioner has a very important role to play because he is the first point of contact with the patient, and therefore he must be well aware of the signs and symptoms, the investigations required, and timely referring the patients to the secondary care center really improves the survival and the outcome. Now, primary care practitioners also play a key role in making the patients aware of the various risk factors like obesity, diabetes, hypertension, unopposed estrogens for menopausal hormone therapy, polycystic ovarian diseases, and then telling them how preventive strategies by changing lifestyle can really help them reduce the risk factors. And there are various screening methods that can be used. Now, today we have a very eminent and a learned, renowned speaker, Dr. Vinota Thomas. She is Associate Professor, Department of Gynecological Oncology, Christian Medical College, Vellore. And she will be talking on recognizing endometrial cancer in primary care center, red flags and referral. So over to Dr. Vinota. Do you have to say anything, Dr. Rekha?
Nothing particular to say. It is a pleasure joining the Patna Ops Gynae Society, and I'm thankful to the organizers to have given me the opportunity to be on the panel so that I can really interact and listen to all the learned speakers. And really the topics are well chosen and of good interest. So I will ask the speaker, Dr. Thomas, to start her speech, and later on, maybe we can ask her some questions. So over to Dr. Vinota Thomas.
Thank you, ma'am. And thank you for all your kind words. Thank you, Patna Obstetrics and Gynecology Society for this invitation. And I thank Dr. Priya and Dr. Vinita for the personal invitation. Are my slides visible? Am I audible?
Yes, yes.
Yes, sir. Thank you.
Yes, ma'am. Yes, ma'am.
Yeah, thank you. So I'll be talking about recognizing endometrial cancer in primary care settings, the red flags and referrals. Now, before I start, I would like to throw some light on the cancer statistics with regard to endometrial cancer in India. Now, from Globocan 2020, this is from WHO. In India, in 2020, there were 601,000 new cases of endometrial cancer, and it constitutes about 4% of all women cancers. Now, this is probably not as common as breast and cervical cancer and colorectal cancer, but this is still the 7th most common cancer in India. Now, we look at age-specific rates. It's most common in the mid-6th decade. These rates are from Assam, and we look at survival from hospital-based studies. The 5-year survival rate for early cancer is about 80%, and this was from Cochin. When you look at risk factors for endometrial cancer, as ma'am had previously mentioned, reproductive risk factors include nulliparity. Menstrual risk factors include chronic anovulation, late menopause. Unopposed estrogen is a key factor for endometrial cancer. This could be unopposed estrogen, though we don't usually see as in estrogen-only pills, or following tamoxifen usage as prophylaxis for breast cancer, or in estrogen-secreting tumors such as sex cord tumors. Anthropometric risk factors include obesity, lack of physical activity. Medical conditions include diabetes, polycystic ovarian disease, and host factors include Lynch syndrome and Cowden syndrome. When we look at modifiable risk factors which we can modify, to note these are menstrual risk factors, hormones. We can definitely interrupt unopposed estrogen, tamoxifen and estrogen secreting tumors. And a biggest modifiable risk factor is obesity and lack of physical activity. And other medical conditions that we can modulate probably are diabetes and polycystic ovarian disease. When you look at India and obesity, this is becoming a big problem. Now, prevalence of overweight and being overweight and obesity has reached epidemic proportions. When you look at this graph from a national data, we can see how the blues have become orange and red when compared to 1990, as seen in 2016. Now I come from Tamil Nadu, and it's bright red. We have high obesity rates, and we share similar statistics with Kerala, Punjab, and Uttarakhand. Patna has still low prevalence rates, but then there doesn't seem to be any decline in these rates. And India has a distinction to rank among leading countries with high prevalence of both undernutrition and obesity. And recent data, about 15% of women were overweight in 2005. When compared to 2015, about 31.3% of women are overweight. And about 5% of them have BMI more than 35. And if we continue with this current trend, we are going to reach probably disastrous rates by 2040. Now, why is there so much of hype about obesity? This is linked to about 13 cancers. Forget about its linkage with cardiovascular diseases and cerebrovascular diseases. These 13 cancer types include breast cancer, colorectal cancer, gallbladder cancer. Colorectal cancer is about the 3rd most common cancer among Indian women. And unless we promote healthy lifestyle, as Madam had said, we are going to see increasing rates of endometrial cancer. Now, the key question, why do we need to identify red flags? As mentioned earlier, primary care gynecologists are likely to be the first point of contact for patients with gynecological cancers. And on average, primary care gynecologists can be meeting or can be in contact with at least one patient with gynecological cancer. The majority of the patients they see might not have gynecological cancer. And hence, it is important to identify red flags as this expedites diagnosis of endometrial cancer. Now, endometrial cancer, as unlike cervical cancer or ovarian cancer, where most of them come with stage 3. These patients present early and they are often symptomatic. Cervical cancer, as Dr. Priya Ganesh would say, screening, there's a preclinical phase, and therefore screening is important, but most of our patients come at stage 3. Whereas endometrial cancer, most of them are identified in stage 1. Now, disease-specific survival is heavily stage dependent with 5-year survival of 95% and 14% for women diagnosed in stage 1 and 4 respectively. So the objectives of this presentation is to highlight red flags of endometrial cancer and when to refer them, and clinical scenarios will probably put these two together. So how do we identify red flags? Now, red flags are identified through history. This include familial risk factors and physical examination. Now, in postmenopausal women, the most common red flag is postmenopausal bleeding, which is seen in 90% and can be confused with hematuria. On the corollary, 90% of postmenopausal bleeding can be due to other causes other than endometrial cancer, but 90% of the time, endometrial cancer presents with postmenopausal bleeding in these women. Less commonly, symptoms are discharge and pyometra. In the pre-women, we see them with menstrual bleeding or of chronic anovulation. Now, risk of endometrial cancer increases with increasing age, but we do see women as young as 28, 35 with endometrial cancer. Polycystic ovarian syndrome and obesity are have a risk ratio of about 2 to 3 fold increase, and family history of colorectal and uterine malignancy are often associated with endometrial cancer, though family history of colorectal cancer is only seen in about 5% of patients. We go to the diagnostic pathway. Important is which
You're
can
not
be followed by endometrial biopsy can be done before ultrasound. Sorry, I think I got out. Can you see my screen?
Yeah, we can see now.
Sorry. Sorry, I think so. Transvaginal ultrasound scan followed by endometrial biopsy is important. To endometrial biopsy can precede transvaginal ultrasound scan based on our index of suspicion. Sorry. Yeah. We can do hysteroscopy in case of focal pathology or when recurrent bleeding when endometrial sampling is non-diagnostic. Blood investigations which can be included are hemoglobin, sugars, and urine routine. So how do initial thickness or 4 mm or more or 5 mm or more, depends on which society or which society guidelines you're using, can be used, and they have a false negative rate of 4%. But then this is not reliable in premenopausal women as this endometrial thickness can vary in as per the menstrual phase. Besides endometrial thickness, character of the endometrium is also important. This might mean irregularity, heterogeneity of the endometrium, cystic changes, and absolute tumor volume. Grayscale and color Doppler sonographic features help differentiate malignant from non-malignant features. This is a normal endometrial thickness. This may vary in premenopausal women, but the usual cutoff is 4 or 5 mm in postmenopausal women. Now, if we lower the endometrial thickness, obviously sensitivity is going to increase, but that is going to be at the cost of specificity. So an acceptable range is 4 to 5, but then type 2 cancers can present with thin endometrium. On the contrast, you can see this of rather heterogeneous, cystic, highly thickened endometrium, and this is how we see when we put on color Doppler, which is a highly vascular tumor. So both grayscale and color Doppler sonographic features help differentiate malignant from non-malignant, especially in differentiating a polyp from a non-polyp. Now how do we clinch the diagnosis? This can be done using endometrial sampling or biopsy. This has replaced traditional endometrial curettage, where we probably sedate the patient, we hold the cervix with the valsalum or a tenaculum, and then we use a curette and then scrape the endometrium. Endometrial sampling or aspiration is based on vacuum aspiration, and it's got similar diagnostic accuracy to traditional diagnostic curettage. There's a sensitivity of 90 to 100%. This is an outpatient basis, less painful, as you can see in these pictures. We don't need to hold it with a valsalum or a tenaculum. We insert the catheter, and then we create a suction by withdrawing the piston, and then we just rotate the suction, and this quickly fills up. So this is similar to use of a common cannula or any other suction device that we use for abortion, except this is very thin and it does not require any dilatation. And hence, most patients can accept it. This can be done on the bedside. Most of the times, we just do it without even putting the patient in stirrups. We just let the patient be in dorsal position, and very often we get our biopsy done. And women with benign or inconclusive histology, such as those with heavy bleeding or suspicious ultrasound findings where you doubt the biopsy report, or with endometrial sampling is inconclusive, these kind of patients should be offered outpatient hysteroscopy to target biopsies. Now, when you look at FIGO, this is especially important when patients with abnormal uterine bleeding. It is very easy to diagnose endometrial cancer in women who come with postmenopausal bleeding, but those women who come with irregular bleeding, when do we do a biopsy? Do all patients require biopsy? So then we need to assess the patient's risk of hyperplasia or neoplasia, and then we proceed with an endometrial biopsy. So these risk factors might include age, more than 45, but then this is not absolute. We look at personal and genetic risk factors such as obesity, polycystic ovarian syndrome, family history, and we also look at the transvaginal ultrasound scan. We'll also look at, besides the mere thickness, we also look at the heterogeneity, the cystic component of it, and the color Doppler. What is important is a one-stop clinic. One-stop clinic where patients are scanned, they review the scan on the same day, and are offered endometrial sampling on the same day. Obviously, this reduces delay, ensures patients' compliance, and improves patients' experience, and is cost-effective. The other red flags which we need to note are in patients who are premenopausal, who are obese with polycystic ovarian syndrome, and who have family risk factors with irregular bleeding or intermenstrual bleeding. Very often we see atypical glandular cells on a cervical smear. It's very important in a postmenopausal women. But in premenopausal women, if they are not in their period, these have to be evaluated. Endometrial cancer has to be excluded in those who are obese or with chronic anovulation. What do we do with incidental finding of a thickened endometrium? No, we don't have clear guidelines on this, but then clinicians have to use the discretion, taking patient preference and risk factors into account. If you want to follow them up, make sure patients come back to you, and you're very sure that they will really come back to you, especially when those aren't tamoxifen. Now, referral to a gynecologic oncologist or gynecologist with oncologic expertise. When do we refer? Definitely with endometrial malignancy. We also would advise to refer those with precursor lesions, such as hyperplasia with atypia or endometrial intraepithelial neoplasia, which both of them have a risk of progression to malignancy, about 8 to 28%. They also have a chance of coexistent malignancy about 1 to 40%. Now, briefly about hyperplasia with atypia and endometrial intraepithelial neoplasia. They are not two similar terms. Hyperplasia with atypia is used with the WHO 2014 classification. It's a two-tier classification. We've probably learned in our postgraduate days. We had hyperplasia, simple hyperplasia with atypia, complex hyperplasia and complex hyperplasia with atypia. In 2014, WHO has replaced it with two-tier classification. This reduces interobserver reproducibility. The term endometrial intraepithelial neoplasia is suggested by ACOG and SGO. It is not similar to the hyperplasia with atypia, and this probably represents a biological basis for endometrial cancer. Now, why do we need to refer to a gynecologic oncologist or a gynecologic oncologic expertise? After all, they're only going to require a hysterectomy. But then, we always support our things with evidence, what we have to say, and there is evidence. This was published in 2011, where they found that patients with endometrial cancer, when treated by a gynecologic oncologist, were more likely to undergo staging surgery. Endometrial cancer is surgically staged, and unless we perform a decent staging surgery, we are not going to know whether she's stage 2 or stage 3 or stage 4. And those patients with stage 2 and stage 3 and stage 4 receive adjuvant chemotherapy for advanced disease. And this was shown that care by a gynecologic oncologist made a difference to disease-specific survival for stage 2 and for stage 4 disease. What is important is based on the study ESTRO, that is the European Society of Radiation Oncologists, the European Society of Gynecologists, and ACOG guidelines. The American College mandate referral to a specialized center with a dedicated team or specialists. And what is most important is multidisciplinary decision. And this is recommended as the best practice in treatment planning and care for patients. And this can be seen only in specialized centers with a dedicated team or specialists. And this is, it's quite, it's established care in most gyne-oncologic centers in India also. Now, I would like to share some of my viewpoints and what we have observed. We see a lot of patients who have hysterectomies in postmenopausal bleeding without endometrial biopsy. And it makes our hearts sink because we don't know what to do with them next. We also see premenopausal patients undergoing myomectomies and morcellations of uterus with underlying malignancy. Then we see patients with subtotal hysterectomy with the cervix spared, and all this results in delay to adjuvant treatment and peritoneal dissemination. We published some of our observations in 2018, and we saw 20 cases who had completion surgery following inadequate surgery, and about 40% of them had no biopsy before the surgery they had in their center, and even ovaries were preserved in about say about 60% of patients who had a hysterectomy, and hence we mandate that patients should be referred appropriately based on identification of red flags. Now, this is just not our observation. This observation came from AIMS Jodhpur, and Garima was my friend, who published that following post-hysterectomy and post-myomectomy, overall there's a 4% identification of malignancy following surgery for benign conditions, and 0.4% following hysterectomy and 2.8% following myomectomy, but this included uterine malignancies such as sarcomas and stumps. Now, I'd just like to put all my red flags and referrals together and clinical scenarios I'd like to share. So we had a 34-year-old primary lady with primary infertility for 13 years who presented with irregular bleeding for 6 months. She came to us 10 days following laparoscopy proceed open adenomyomectomy. She had a BMI of 45, and this was a biopsy report. In the myoma specimen, she was reported to have moderately differentiated endometrioid adenocarcinoma, and this was her biopsy report. And she underwent a laparoscopic proceed open adenomyomectomy. Yeah, there's some voice on the background.
Yeah. So, Chitrakala, can you just mute everyone other than speaker?
Thank you so much. So, so the presumed diagnosis on this ultrasound scan was submucous fibroid, and we probably can see how costly this diagnosis was. We subjected her to repeat laparotomy after 30 days from the initial surgery. She underwent total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and excision of tumor deposits. In short, the uterus was 16 weeks. The obviously stage 1 disease had progressed to stage 4 disease with omental deposits and bowel deposits. The left retroperitoneum was fibrosed with a large nodal mass of 6 into 7 centimeters along pelvic wall. The patient developed post-op DVT and deteriorated and died 3 months from date of initial surgery with chest radiation for her pain. This is a 34-year-old woman who died of disseminated following a and I have shared this for index of suspicion was biopsy the endometrium. Clinical case 2. This is another young lady, 38-year-old lady. She came from Bangladesh with primary infertility, with severe pelvic pain and abdominal bleeding following diagnostic histolaparoscopy for infertility. She weighed 108 kilos. And in her diagnostic histolaparoscopy, the findings noted were she had polycystic ovarian disease. There was only one line description of the histoscopy, ostia not visualized. And the endometrial biopsy was very cryptic. It showed cells with mitosis and necrosis. Differential diagnosis included decidualized endometrial stroma, histiocytes, clear cell or signet rings. You usually see at the bottom of the biopsy, there's an impression that was a miss in that endometrial biopsy. Based on our clinical suspicion, we did a biopsy and she had grade 2 endometrioid carcinoma. So this was her radiological imaging. This is a cross-sectional of her MRI. You can see these large pelvic nodes. This tumor is breaching the serosa. And you can also note this large retroperitoneal nodes. So she had clinically stage 3C2 disease, and this corroborated surgically when she had surgery. So what's important is we need to know our pathology. On my left is atypical hyperplasia. We can see crowding of glands. There is some atypia, but not so much as grade 1 endometrial carcinoma. There is lack of stroma. And when there is nuclear atypia and increased mitotic rate, we call atypical hyperplasia as grade 1 endometrioid carcinoma. Both of them can coexist in 50% of the cases. So this is clear cell carcinoma. This is we see 3 patterns: tubular pattern, solid, and glandular. So this is a tubular-cystic pattern, and what we can see is hobnailing of cells, as we see in these cells. On my right is serous cancer, where obvious papillary histology, papillary pattern. Scenario. We had a 44-year-old lady who was presented with intermenstrual bleeding for 2 months. She underwent endometrial hyperplasia, endometrial biopsy, which showed hyperplasia with atypia, and subsequent. Because she had 44, she had laparoscopic hysterectomy, where the ovaries were retained. And biopsy report was carcinoma with more than 50% myometrial invasion and cervical stromal invasion. So this was a CT scan when she came to us 15 days later, again large nodal mass, and we retook her family history. Her father had colon cancer. 2 paternal aunts had uterine cancer, and her brother had colon cancer, and this patient was now diagnosed to have uterine cancer. Now, if somebody had just taken that family history before proceeding on to the laparoscopic history, what somebody would have done the right surgery at the right time. Not that 15 days would have made a difference, but then this patient is having to wait for a second surgery, again delay for an adjuvant treatment. Now we see this trend of visiting surgeons. They go from hospital to hospital doing laparoscopic surgeries, and history taking, clinical examination is often a miss because they're quickly worked up and nobody sees them with an oncologic perspective, or it might be just a very junior person taking history and clinical examination. And this should not be repeated. And I just brought this up to put our red flags and referrals together. So a brief word about Lynch syndrome. Lynch syndrome is associated with colorectal cancer, stomach and pancreas and urinary tract and ovary and uterus cancer in women. It can be associated with prostate cancer in men. And very often uterine cancer is the primary cancer, or it heralds the rest of the cancer which can occur in women, and very often they then subsequently develop colorectal cancer or stomach cancer, and hence the importance of family history. To conclude, we need to be aware of risk factors for carcinoma endometrium. These include obesity, polycystic ovarian syndrome, and family history. Identify red flags. Postmenopausal bleeding is the key red flag, but then premenopausal AUB can also be a red flag. Never miss on endometrial sampling or biopsy. Office procedure can be done bedside. And last, please refer to gynae oncologist accordingly. Thank you so much for your time and for your patient listening.
Thank you, Dr. Vinita. It was an excellent presentation. Hello?
Yes, you're audible.
Yes, you.
Dr. Vinita is an excellent gynec-oncologist, and the presentation was very nice. But first of all, I would like to thank Foxy, who has introduced gynec-oncology as it's one of its committee, and Dr. Bhagyalakshmi Naik, who had worked so hard that each and every gynecologist now is having gynec-oncology in her brains. Now all the gynecologists are very much aware. And Dr. Vinita has very nicely said that it is very important that we have to diagnose, we have to identify the red flags. We have to be very carefully, we have to take the family history. We have to, even if we are not aware of the disease, when we are doing surgery, then we have to, for each and every patient, the pathology, histopathology has to be done. That is very crucial. Even if we are not able to identify, the sample should be sent for histopathology, and then at least you send the patient early to a gynecologist so that the right surgery may be done at the right time. So it was an excellent presentation, and I thank Foxy, and especially to I would like to thank Dr. Priya Ganesh, who is really taking interest, and I love to see her every time, and I hope in her tenure will really achieve something very good, at least for the cervical cancer cases, which is really a preventable disease. So we have to prevent that preventable disease also. Thank you very much. And Dr. Supriya and actually both our president and secretary both are very beautiful. So thanks to the president and beautiful secretary. Thank you.
Thank you. Renudi, you are muted. Renudi, you are muted.
So the take-home message for today, after today's talk on endometrial cancer, is that any patient coming with irregular postmenopausal bleeding or even premenopausal, if the patient is coming, we must always take a proper history, consider her risk factors, and first diagnose and rule out endometrial cancer before we proceed on for any hysterectomy. And if there is any doubt, the suspected patients should be referred to a gynec oncologist so that we can do justice to the patient, and timely, proper surgery followed by adjuvant therapy can be given to them. And one thing more, I must say, that we just see the endometrial thickness, but the color Doppler that Dr. Vinota has said is very important. The heterogeneous cystic appearance of the endometrium and the color Doppler appearance can also go a long way in helping us to diagnose between benign lesions and malignant. So these two things I really thought was very important. And in the end, I say that it was really excellent to hear you, Dr. Vinota. It was wonderful. Thank you. Any questions from the audience? Any questions? Anybody wants to ask any question?
As such, chat box, but there is no question.
Okay, so we proceed.
It's only the appreciation of the talk.
Bahut acha. Very nice.
Very nice.
So thank you. Thank you, the speaker, Dr. Vinota, and thank you all the chairpersons, Dr. Renu Radgi, Dr. Rekha, and Dr. Sangeeta. That was the wonderful talk and wonderful inputs from the chairpersons, and very good take-home message also. So now we move on to the second session. The topic of this session being approach to adnexal cell masses. So I think ovarian cancer will be taken upon in this session. Again, the very notorious ovarian cancer for diagnosis. So let's get the detail by Dr. Vinita Gupta. To chair this session, may I invite Dr. Abha Rani Sinha first. Madam Dr. Abha Rani Sinha is the strength of our society, I must say, and a very sincere and dedicated senior member of our society. And we all know that she's encyclopedia of Obs and Gynae. And she needs no introduction, just to do the formality. Dr. Abha Rani Sinha is a professor and HOD Obs Gynae Department, SKMCH Muzaffarpur. She is ICOG Governing Council member, President Patna Obs and Gynae Society 2017-18, Chairperson Quiz Committee Foxy 2015-17, and she's National Corresponding Editor Jogi right now. And she's UG and PG teaching, had teaching experience of more than 26 years. Contributed many chapters in Foxy publication. She has been joint organizing secretary AICOG 2014, and she has special interest in high-risk pregnancy and vaginal surgery. And she has been awarded with MS Signature Award in 2021. So welcome, Abhadi. Now I wish to invite Dr. Rita Sinha as a chairperson. Dr. Rita Sinha is a very senior member of our society, a very humble and knowledgeable member of our society, and she guides us as our guardian, I must say. Dr. Rita Sinha is a senior consultant, Department of Obs and Gynae, Mahavir Vatsalya Hospital, Patna. She is president, ISOPAR Patna chapter. She is joint organizing secretary of Foxy AICOG 2014, undergraduate and postgraduate and DNB examiner of PG guides. She has teaching experience of more than 34 years, and she is also coordinator of EMOC and BMOC program. So welcome, Dr. Rita Sinha, Dr. Rita Di. Now I wish to invite Dr. Vinita Trivedi, a very active member of our society, in the sense she is ever ready for organizing and in taking part in all the awareness program and camps. So thank you, Vinita, for that. Dr. Vinita is senior consultant and heading the Department of Radiation Oncology, Mahavir Cancer Sansthan. So over to all the chairpersons to start this session. So at the outset, may I request Dr. Abha Rani Sinha to introduce and invite the speaker, Dr. Vinita.
I request Dr. Rita Di will be introducing.
Okay, so I invite Dr. Rita Sinha to please introduce the speaker. And thanks Vinita and Supriya for inviting us to be a part of this very informative Foxy Oncology Committee webinar. So Rita Di, please introduce the speaker.
Okay, good evening everybody. First of all, I am thankful to the organizer for giving in front of you Dr. Bindya Gupta is Associate Professor Obstetrics and Gynae UCM and GTB Hospital, Delhi. She is Commonwealth Scholar, Gynecological, Pan Birmingham Hospital and Gynae Onco Center, UK. She is IFCPC IARC certified colposcopist. She is having around 70 international and national publications and editor of 6 books. She has several awards in national and state conference, received Foxy Korean Award in 2018. Now I request Dr. Bindya Singh Vindhya Gupta, please start your talk because your talk is very important about adnexal mass, and no gynecological examination is without knowing about that adnexal mass. So please start your topic. Thank you.
Good evening, everyone. Thank you very much, Madam, for the kind introduction. At the outset, I would like to thank Dr. Vinita Singh and Supriya, Madam, for giving me this opportunity. Thank you, Dr. Priya Ganesh, Ma'am, for giving me this opportunity to be here in this August gathering. So, as Ma'am said, that is a very important topic. This in our day-to-day practices, we see our adnexal masses, ladies coming there, and we have to make accurate diagnosis and reach at a definite for the definite management. So, my topic today is approach to adnexal masses. So, as I said earlier, accurate characterization of adnexal masses is important to define the appropriate treatment pathways. And a preoperative assessment is important because what we need to identify is the risk of malignancy and accordingly tailor our management. And for this purpose, it's not only one, but it is a combination of clinical presentation, imaging, and tumor markers, which we have to take hand in hand to arrive at a definite diagnosis. So starting from history, it is very important to identify the high-risk groups always. So extremes of age, either be it premenarchal and postmenopausal ladies, they're very high risk of having a malignancy if they're present with adnexal masses. Then nulliparous women, then women with history of infertility, endometriosis. Then family history is very important. The BRCA syndrome, the breast, ovarian, endometrial, and colorectal cancer history in family relatives. It's very important to identify these high-risk groups as they have a higher risk of having a malignant mass. In our institute, we did a retrospective analysis of the adolescent ovarian masses, and we found that girls who are in early adolescence and they come with an adnexal mass, there's a higher chance of having malignancy as compared to girls who present in the late adolescence. So that is why it's very important to identify the high-risk groups. Then comes the symptoms. As it's well known that ovarian cancer is a silent killer. It normally talks in the third stage or advanced stages. So it's very important to identify certain symptoms and certain symptom complexes which help us to arrive at a definite diagnosis. So the modified Goff symptom index identified 8 symptoms which are clustered into 4 groups, which included pelvic or abdominal pain, increased abdominal size or bloating, difficulty in eating or feeling of fullness, increased urinary frequency or urgency. And if any of these 8 symptoms are present for more than 12 times per month for less than 1 year, the symptom index was considered to be positive, and it had a sensitivity of around 65% and around an 85% specificity for diagnosis of ovarian cancer. We had the similar symptom index tested in our population in our hospital, and we found that symptom index again had almost an 80% sensitivity and 88% specificity for predicting ovarian cancer. And in our group of studies, abdominal pain was the most prevalent symptom with a sensitivity of 84%, and most of the symptoms appeared within 3 months of diagnosis of cancer. So what is important is that we should listen to the patient very carefully, because normally in our practice we disregard these these non-specific signs and symptoms. The other manifestations, they can be abdominal pain, a palpable abdominopelvic mass, acute abdominal pain, distension. Then also women then present with certain hormonal irregularities like menstrual irregularity, presence of vaginal bleeding, hirsutism, virilization, and fever. So these are also certain red flag signs which we should take into consideration when we are dealing with adnexal masses, and they may be a sign of cancer. Then coming to examination. So when we do an examination, especially pelvic examination, what are the features which suggest malignancy? Presence of irregular nodular masses, solid, fixed, bilateral, nodularity in the pouch of Douglas, presence of ascites. These are the features of malignancy. However, there may be some limitations if the patient is obese, or they may be limited by examiner's experience. And certain benign conditions like endometriosis, masses, etc. may mimic these symptoms. But yes, we should never ignore these features when we're examining the patient. Look for them. So once we've done a detailed history and examination, then we come to the second important aspect is imaging. Imaging a simple good ultrasound, which is a combination of a transvaginal sonography and a transabdominal sonography, carries almost a 90% sensitivity in characterization of adnexal masses, in detecting which masses are suspicious or may harbor malignancy. And if you add Doppler to it, the specificity further increases to 91%. So this is the first line and the most important line of investigation. And as you can see, the accuracy of this investigation is almost comparable to MRI. So this should be the first step in the evaluation of an adnexal mass. Various ultrasound-based morphological characteristic and risk prediction models are there. One of them by the IOTA group, which can be the simple rules. Then they have certain logistic regression models. And then various models have been developed by the American College of Radiology, which are morphological indices. Then there are certain model systems like GIRADS and ORADS. I'll be discussing them briefly one by one. So the IOTA, or the International Ovarian Tumor Analysis Group, they gave certain rules to classify the masses as benign rules or malignant rules. So what are the benign rules? Presence of unilocular cyst, presence of certain solid component, but which is just less than 7 millimeter, presence of acoustic shadowing, then a smooth multilocular tumor, which is the largest diameter of less than 10 millimeter, 10 centimeter, and no blood flow. These are the B rules or the benign rules. What are the M rules? If the tumor is irregular, solid, there is ascites, at least 4 papillary structures are present, or there's an irregular multilocular solid tumor with the largest tumor diameter of more than 10 centimeter and has a very strong blood flow. These are the M rules. So if one or more M rules apply, in the absence of benign rules, it is a malignant mass. If one or more B rules apply, in the absence of M rule, the mass is benign. And if both M and B rules apply, then we can say it is an inconclusive mass, and we may need to go for further imaging like MRI for characterization. So it has a good sensitivity of 90% and specificity of 93%. Then certain logistic regression models have been developed by IOTA, and this is available on the website. Just fill in these models, and with these points, age, ascites, etc., these points can be filled, and then you can arrive at what is the risk probability of whether you're dealing with a benign or a malignant mass. Then coming to a very important system called the ORADS, or the Ovarian Adnexal Reporting and Data Imaging System. With the ORADS, this is developed by the American College of Radiology, and they give a risk probability that what is the likelihood of malignancy if they fit into this model. With ORADS 1, there's zero likelihood of malignancy. ORADS 2, it is certainly benign. Then ORADS 3, there's low risk. And it is the ORADS 4 and 5 which carry an intermediate and high risk of malignancy. So these are all the morphological characteristics which have been explained in the ORADS model, and we can just correlate them according to the on imaging. So not only this system tells you that whether this is a benign or a malignant mass, but it also helps you to guide management. For example, if you have ORAD score of 2 and you're dealing with an almost certainly benign mass, in that case, see what it is. It is a simple cyst, or there are benign lesions, or there are certain unilocular cysts which are non-simple. In that case, you can see whether you need to follow them up, or and what is the frequency of follow-up. So like follow-up in 8 to 12 weeks, and then you can follow them in 1 year. In case you have any doubt, then you can also refer them to a specialist who specializes in doing the ultrasound, or you can even go for an MRI. Therefore, this system also helps to tell you what the management should be accordingly. Similarly, for low risk masses, again, the ultrasound should be done by an ultrasound specialist, or you can also go for an MRI, and these can be managed by a gynecologist. But intermediate risk masses and high risk masses are the one where you should refer them to a gynecologist, or you should at least consult a gynecologist when you encounter such kind of masses. Then other imaging modalities like CT, MRI, and PET, they should never be done on the first instance. CT scan should be done only when you're dealing with malignant ovarian masses to assess the spread and operability, or whenever you're trying to decide whether you want to do a neoadjuvant chemotherapy or whether you want to take up for primary upfront debulking surgery. MRI is useful, especially when you want to distinguish the inconclusive masses, or when you want to differentiate the origin of non-adnexal pelvic masses. PET CT is not very useful, and therefore a lot of the patients, they come with PET CT in this, and it is not useful for preoperative assessment for adnexal masses. We should all keep in mind. a very important aspect before I go to the tumor markers is that I think as gynecologists and as gyne-oncologists, we should do our own ultrasounds. We should try to assess what masses we are dealing with, and we should train our eyes, we should train ourselves in doing our own ultrasounds, and then only we can, improve our diagnosis of adnexal masses. So now coming to the tumor markers, we all know CA125 is the most common tumor marker which is done. Everybody, even the patients now Google up and they come with CA125 reports. So normal serum levels are up to 35. And however, it has low elevation in the early stage ovarian cancers. And majority of them, when they come with elevated CA125, are in the late stage. CA125 is majorly expressed by epithelial cancers. However, they can be elevated in benign conditions like PID, endometriosis, and even physiological conditions like pregnancy also. So therefore, there was another marker which was introduced was HE4. HE4 has a higher sensitivity compared to CA125 at the same specificity, and it is not affected by physiological conditions and endometriosis. There's another algorithm called Roma algorithm or risk of ovarian malignancy algorithm, in which depending on the CF125 and HE4 levels, cutoffs are designated. And if the cutoff is more than 1.3 in premenopausal, the chances of malignancy is high. And in postmenopausal women, this cutoff is taken as 2.7. The other tumor markers which are done are CEA. CEA are usually done basically when a lady presents with bilateral ovarian masses. It can be metastatic. So therefore, especially from the GIT, a high CEA usually suggests that yes, maybe we are dealing with a non-ovarian pathology. Maybe it's a GI malignancy. However, one important thing I would like to suggest here, see the ratio, CA125 to CEA. If it is more than 25, it is more suggestive of a primary ovarian cancer. Since CA15.3, it is usually elevated in breast malignancies. And if we have an elevated CA15.3, it warrants a mammography and breast evaluation. Then CA19.9, it is elevated especially in mucinous adenocarcinomas. However, it can also be elevated in a pancreatic primary, and therefore it needs to be accordingly investigated. Then germ cell tumor markers, we all know beta HCG, AFP, LDH, and CA125, they can elevate it in the various germ cell tumors. What is more important is that any woman less than 40 years of age with suspected ovarian cancer always get these tumor markers done, because you never know, you may be dealing with a germ cell ovarian tumor. Then coming to the sex-caused stromal tumors, we all know inhibin is a marker for the granulosa cell tumors. So how it is important, so whenever a lady presents with a adnexal mass with some hormonal manifestation, especially menstrual irregularities, in that case, we should always get inhibin levels done. Other tumor markers for granulosa are AMH and even activin. For sertoli-lytic cell tumors, we have testosterone, and for carcinoid tumors, we have the 5-hydroxyindole acetic acid as a tumor marker. Now, combining this imaging and tumor markers, certain combined algorithms are being practiced, and they are very useful in routine practice. We all know the RMI, or the risk of malignancy algorithm. It basically it combines the ultrasound score, the presence of what is the menopausal status, and what is the CA125. So basically, it's a product of the ultrasound score, the menopausal status, and the serum CA125 levels, which are measured. An RMI-1 score of 200 carries a sensitivity of almost 78% and specificity of 87% in categorizing whether we are dealing with malignant masses or more. So basically, a cutoff of 200 is taken. More than 200, it is more likely to be a malignant mass. Then IOTA ADNEX model. Now, IOTA came up with an ADNEX model. It is very, very useful. It is available on the website. It is available as an app. It again estimates the probability that whether we are dealing with an adnexal benign mass or a malignant mass. And not only that, it also tells you whether it is a borderline cancer, what stage of cancer, or whether it is secondary metastatic cancer. It is a very good risk probability index. So again, you have to just feed these 9 parameters in the app, and this is the model: the age of the patient, oncology center, whether the ultrasound is done at an oncology center, what is the maximum diameter of the lesion, what is the maximum diameter of the largest solid part, number of locules, so whether there are more than 10, yes or no, number of papillary projections, whether acoustic shadowing is present or not, whether ascites is there or not, and what is the serum CA125. And then just press calculate, and this is what the chart you get. So what is the chance of benign tumor? What is the risk of malignancy? And if it is malignant, what is the probability whether it will be borderline, stage 1, or stage 2 to 4, or metastatic? This is how the ADNEX model works. So on the validation data, at a 10% cutoff for total risk of malignancy, the sensitivity was as high as 96.5% and the specificity was around 70%. Now, in a hospital, we did a study with ADNEX model. We had around 60 cases we tested. And at a 10% risk of malignancy, again, we found very good sensitivity and specificity for prediction of risk of malignancy in adnexal masses. And this was the ROC curve which we made. And the ROC area under the curve was a very good 0.9. And at a cutoff of 53% in our study, the sensitivity was 85% and specificity was 96% in predicting the risk of malignancy in adnexal masses. A very beautiful flowchart has been suggested by the ESO group for preoperative assessment of ovarian tumors, and how they proceeded with the algorithm I'll just describe in detail. So patients with symptoms suggestive of adnexal masses, or if they're incidental finding of adnexal masses, do an ultrasound assessment. If it is normal ovary, that is ORADS 1, go for conservative management. You can discharge or repeat the scan in 6 weeks. If they're non-physiological findings, get an expert ultrasound assessment or go for IOTA ADNEX model, which I just explained. So then you see, if it is certainly benign, its risk is less than 1% or it's ORADS 2, just keep her on follow-up. Conservative management follow-up in 3 to 6 to 12 months. If the risk of malignancy is low, that is it's ORADS 3, that is around 1 to 10% risk of malignancy, it can be managed in a general gynecology unit. But then be very, very careful if you're dealing with these kind of masses. Be very careful if you're going for laparoscopy. Do avoid spillage of the tumor. It's very important. Assess the patient. And if you think that the mass is big, go for an open surgery. If there's intermediate risk of malignancy, please take a gynec oncology into confidence. And if it's ORADS 4, or you can take them into confidence, or you can refer to a specialized gynec oncology center. And if there's a high risk of malignancy with more than 50% ORADS 5, always refer to a gynec oncology center. Never attempt, because we get so many cases who come with incomplete surgery and then we just kind of worsen the prognosis. Stage 3 cancers, just undergoing a transverse, laparotomy by transverse incision, no staging done, and just THBSO, and that is it. So it's very important to identify the masses and send them and manage them accordingly. Now, at a gynec oncology center, what is to be done? You can the expert assessment again is repeated. CA-125 and CA is again evaluated, and other tumor markers in specific cases are done. And if suppose there's any doubt, you can even do an MRI. And the multidisciplinary team meeting, a tumor board is set, and then we can in the tumor board do a staging CT, then do a CCT chest, abdomen, pelvis, discuss in the tumor board, and then accordingly decide for management. So if you're dealing with a borderline tumor, there can be options of fertility sparing if it is desired by the patient. Otherwise, go for complete surgery. And then if it's an early stage or advanced stage, depending on the staging CT or staging laparoscopy, they can go for neoadjuvant chemotherapy or a primary debulking surgery, and accordingly, if the secondary metastasis, then we have to investigate for the primary tumor of origin. And this is basically a comprehensive gynec oncology center is required for this kind of management. So to summarize the entire thing, I have certain case studies so to see how we work up and diagnose and how to manage them appropriately. So case 1, it is a 45 years old para-4 light 3. She presented with us to a right adnexal mass with abnormal uterine bleeding. She had multiple comorbidities like hypothyroidism, and she had splenomegaly, thrombocytopenia, anemia, and she had a bilateral polycystic kidney. Her tumor markers were just like, not very high, 75 or CA-125. And most of the patients, the doctors who had referred to us had attributed her AUB to the thrombocytopenia and the splenomegaly. But when she came to us, we took it with a pinch of salt. We got an inhibin B done. It was 877. Her endometrial biopsy revealed a hyperplasia without atypia. And, we do our own ultrasounds. And this is what we got in an ultrasound. It was a typical Swiss cheese appearance of the tumor, hemorrhagic and solid areas. And we calculated the ADNEX score. It was, the chances of malignancy was 53 almost %. We did a staging CT also, and the patient was taken up for a staging laparotomy and complete THBSO it was done. And this was the intra-op findings. And you can see how beautifully the cut section of the ovary relates with your ultrasound. So as I said, again, again and again, always do an ultrasound. You know what the picture will come in your mind when you will deal her intraoperatively. And the patient came out to be granulosa cell tumor stage 1, and she was appropriately managed. So the second case, this lady was a para 2 live 2 postmenopausal lady with abdominal distension, vomiting, loss of appetite. And these are like, those GOF symptoms which you have to really take into consideration when the patient comes into with these symptoms. Performance score was 2 and CA100 was very high, 4,000. We knew that we are dealing with ovarian malignancy. A staging CT was done with majority disease was in the pelvis. So we decided to go ahead with the surgery. And here I want to emphasize the importance of ultrasound when we're dealing with malignant ovarian masses. So when we did the ultrasound, this was a very, a nondescript ovarian mass. And what we saw was these shadows here with something moving inside. So we thought that maybe, yes, it is the bowel, because CT showed that the bowel planes were lost. With the rectosigmoid, and next score was obviously not required. It is definitely malignant. And what I want to show here, this is the intraop specimen. We did a modified pelvic exentration for this patient, modified posterior exentration. And as you can see the tumor is here, and this is the bowel which was there adjacent to the tumor. So when we did the ultrasound, we had it in mind, yes, maybe we are dealing with this tumor, will be close to the bowel, and we will need to, remove the portion. We need to go ahead with the rectosigmoid resection, and accordingly, we counseled the patient, and this was a high-grade serous ovarian cancer invading the bowel. Then again, see here, I want to emphasize what importance is the ratio of CA125 and CEA. See, both these tumor markers are high, but as I said, the ratio is important. More than 25, it will be more likely to be a primary malignancy of the ovary which we are dealing with. So here the ratio was more than 25, but because CEA was elevated, we did do an upper GI and lower GI endoscopy. And again, here we see multiple loculated masses are there, and this is most likely a mucinous kind of a component. Risk of malignancy again was high with the adnex model, and this is what we got intraoperatively. Multiple locules of mucinous tumor was there, and this was a mucinous cyst adenocarcinoma stage 2. Then this was the patient with an 18-week lump abdomen, and she had a scar endometriosis. All tumor markers were benign, and very nicely this ultrasound shows this mesh appearance, which is very characteristic of dermoid. And this is the posterior acoustic shadowing suggesting a benign mass. At next model showed a benign risk of malignancy was just 6%, and very beautifully we all are very familiar with this typical dermoid. And last case, which I would like to say, huge ovarian mass, normal tumor marker. And this, we went ahead with the ultrasound. So this was a typical mucinous tumor. And what we, and the adnex model predicted very rightly the risk of malignancy was just 20%. And we got, this was a huge ovarian tumor and cut section, again, a mucinous tumor with multiple loculations. And this was a benign mucinous cyst adenoma. So what I want to emphasize here, my take home message is that whenever we are evaluating adnexal masses, it's a combination of clinical suspicion, imaging, and tumor markers. Identify the high-risk groups. It's very important. And imaging is the first line. Combination of TS and TVS with Doppler is the first line of investigation. Identify yourselves with the IOTA, B, and M rules, and train yourself, train your eyes, do your own ultrasounds. It's very, very important. Tumor markers are useful adjunct in diagnosis. We have various risk prediction models available with us, as I discussed, the EDNEX, RMI, ROMA, ORAS, and GIRES. Whatever model you want to use, stick to one and train yourself in using that again and again. And if you have an RMI of more than 200, ORADs of 4, 5, or an EDNEX high malignancy prediction, please refer them to a gynec-oncologist. Thank you very much for patient hearing.
Thank you, Dr. Bindya, for your excellent deliberation on evaluation of an adnexal mass. I think as a general gynecologist, we many a times we encounter these adnexal masses as an incidental finding. And it's very important to at least consider 3 things. Number 1, history and physical findings. And in history, the age and the menopausal status. I think these are the 2 very important things that we should know, apart from the family history. The onset of symptoms, whether the symptoms, if it is a very fast symptom, I think then it points more towards malignancy. And then we have to look at the imaging. I think we shouldn't go for the CT scan at the first instance. What our juniors do, they send the patient for CT. First, we should have a TVS plus TS combined, especially for an abdominal pelvic lump. And we have to add color Doppler to it. I think that will tell us, as a gynecologist, I think we get a lot of information, like, and using this simple IOTA B rules and M rules, we can know whether this tumor is suspicion of benign or malignant, and we can just do this RMI scores. I think that's the easiest one to do. With the tumor marker, usually we go for CA 125 for the patients who are premenopausal or postmenopausal. For younger women, we go for the tumor markers of the germ cell tumors. And then we calculate the RMI, and then with this RMI, if it is more than 200, we have to refer these patients to a gynecological oncologist. And always we should think that the first attempt of doing a surgery in a patient with a adnexal mass, if we are suspecting malignancy, it is better to be done by a gynecologist. Because half-done surgery, I think that is the worst thing. So whenever we are taking up any case, we have to be sure whether it is a benign disease or it is a malignant disease, and accordingly we have to do the referrals. Thank you for explaining us the ORAD score, like 3, I think we can do it, but better to refer. 4, 5, definitely refer. Definitely refer. And of course, all the risk models, the logistic regression scores, I think those are complicated things. You have to go to the net and you don't remember it every time. But yes, RMI, Roma, I think the students should also memorize them. They're often asked in the exams. So thank you, Dr. Bindya, for your very lucid, very explanatory, and very nice and excellent talk on evaluation of adnexal mass. We have a young radiation oncologist with us, Dr. Vinita, who was once upon a time my student. I invite Vinita to give her views on her inputs on this subject. Dr. Vinita, please.
Thank you, ma'am. I just want to congratulate Dr. Bindya Gupta for a very, very excellent presentation. It was very, very clear and it was well explained. And I think, Doctor, I just agree to what Abha Rani ma'am has told, that a proper history, physical examination, and imaging, as she rightly told, that CT scan or MRI and doing hi-fi tests like PET CT should not be done. The basic investigation, especially in the form of transvaginal ultrasonography, and that we have to combine with transabdominal or color Doppler, that should be the first modality of choice. And in any clear, if you are suspecting a case of malignancy, definitely a referral to gynec oncologist is must, because treatment of a malignant ovarian mass is very, very different from that of benign case. And as Abha Rani ma'am has rightly told, that incomplete surgery should never be done, because as an oncologist, I see a lot of cases being referred to us after doing a simple tumor has been removed, and on biopsy, she gets a diagnosis of CA and ovary, epithelial tumor of the ovary or germ cell tumor of the ovary, and then she is referred to us. It's really very, very difficult for us as well as for the patient also to undergo second complete surgery has to be done, and then adjuvant treatment has to be given. So this is very, very important. Whenever you find a mass and you are suspecting that this is malignant, referral to gynec oncologist is must, so that proper management of proper management in the form of cytoreductive surgery. And if you are doubting that this is advanced disease, definitely once you are knowing that this is a malignant tumor based on ultrasound, and you are a very high suspicion of malignancy based on CA 125 or the tumor markers, definitely CT has to be done before you opt for surgery, because you have to know whether it is resectable or not. Sometimes, as you told in your third case, as Dr. Bindya has showed, in the third or fourth case, the disease was very advanced. It was adherent to the bowel, and bowel resection and exentration was done. In those cases, at least we can go for neoadjuvant chemotherapy. We can shrink the tumor, and interval cytoreductive surgery should be offered to all those cases. So we have to identify where to go for upfront surgery or where to go for interval debulking surgery, because if we go for upfront surgery, a proper primary cytoreductive surgery, that the amount of residual should be less than 1 centimeter. This is the definition, and we should always follow. And one more point I just want to clear, that whenever you get for report on tumor markers, it should be interpreted very cautiously. Just based on tumor markers like CA125 is more than 300, 400, you should not jump on the diagnosis of CA malignancy, because it is not very specific. And even in malignant condition, also in a lot of benign condition, we get elevated CA125, as Dr. Bindya has highlighted, in endometriosis and many conditions, benign condition, the CA125 level is elevated. So And these markers, if it is, and even for early stage disease also, it's only 50% of the cases it's elevated. So it is very much important that you should be very clear, and it should be interpreted very cautiously, any markers, before you go or jump on the malignancy part. So with this, I thank everyone for inviting me and for making me part of this very, very nice webinar. Thank you so much.
At the end, I would also like to thank Dr. Priya Ganesh Kumar. I think she is doing a great job conducting these webinars, and I really want to see her dream of Cancer Cervix Mukt Bharat. I think that we all have to work together to do that. We are all with you, Dr. Priya. Thank you so much. And once again, thanks. I thank the organizers on behalf of all the 3 chairpersons, Dr. Rita Sinha Madam, myself, and Dr. Vinita.
Thank you very much, Dr. Abha Singh ji, because we all have to work together. It's all have been everyone's dream. So yes, let's see the dream comes true. Thank you.
Yes, yes, we all are with you, Dr. Priya.
Thank you.
Definitely it will be. So thank you. That's the end of the second scientific session. So I thank the speaker, Dr. Bindya Gupta, for her wonderful talk, and all the chairpersons, Dr. Rita Sinha, Dr. Abharani Sinha, and Dr. Vinita, for the clear message and clear take-home message, and making everything so clear. So thank you, everyone. So moving to the next very interesting part of this webinar, the panel discussion, which will be on cervical cancer. And moderator will be none other than Dr. Priya Ganesh Kumar, Chairperson, Gynec Oncology Committee, FOXY. And she has been just introduced in the inaugural part. But I must say, Dr. Priya Ganesh Kumar is a very dynamic, active, and very hard-working Foxian and chairperson of such an important committee, and doing such a lot. Really, congratulations, Dr. Priya, for everything you are doing, and leading us to make cancer cervix free India. That's a great achievement we'll be doing together. So welcome you, Dr. Priya, for moderating this panel. Will you like to introduce the panelists?
Dr. Nibha, can you go ahead with the introduction?
Okay, sure. So we have many eminent panelists for this important session. So first I invite Dr. N. Sundari. She is Senior Consultant, MS Ramaiah Hospital, and she has been retired from MS Ramaiah Medical College. Her area of interest being high-risk pregnancy, preventive oncology, and teaching as well. So welcome, Dr. Sundari.
Thank you.
Welcome. And next, I wish to invite Dr. Urvashi Miglani. She is oncology surgeon from she has completed her ESGO advanced course in ovarian cancer surgery, and currently specialist Deen Dayal Upadhyay Hospital, New Delhi. And she's also recipient of 5 awards in MBBS for academic excellence. So that's great. So welcome, Dr. Urvashi Miglani. Next, I wish to invite Dr. Nikhil V. Kamath. Dr. Nikhil Kamath has more than 25 years of experience in the field of radiology. He has done a visiting fellowship in radiology at Queen Elizabeth Hospital, Birmingham, UK, and neuroradiology fellowship from Ohio State University Hospital, Columbus, Ohio, USA. So welcome, Dr. Nikhil. Now I wish to invite our own Dr. Rajesh Kumar Goswami, a well-known surgical oncologist of Patna and Bihar. And his Director Sun Hospital at Patna. He worked as Senior Consultant Surgical Oncologist, Mahavir Cancer Sansthan for 5 years. Welcome, Dr. Rajesh. Now I wish to invite Dr. Kusum Jashnani. She is Professor and Head Pathology Department, BYL Nair Charity Hospital, I think, and Topiwala National Medical College, Mumbai, MD Pathology. And her special interest in gynec pathology, placental pathology, maternal autopsy, and cytopathology. She has many publications as well. Welcome, Dr. Kusum. And at the end, I wish to invite Dr. Puneet Chandana. Puneet Chandana is a precision oncologist
who holds MD in internal medicine and has PhD in biophysics. And he has many achievements to his credit. So welcome, Dr. Puneet. So with these eminent panelists, may I request Dr. Priya Ganesh Kumar to start the panel discussion. Over to you, Madam Dr. Priya.
Yeah, thank you very much, Dr. Niba. And I welcome all my esteemed panelists. And this is like a tumor board after Dr. Vinita and Dr. Bindya, who have set the ball rolling and the standards high. Let's see how much is this taking up. So we have case discussions, and this is precisely on cervical cancers now. So with me are eminent people from across the country who have been dealing with these cases. And as a tumor board, like suppose if what Bindya said was you actually, on a Gynae Onco platform, what do? You actually get the case, you set it them in front of the tumor board and then decide how to take it up. So precisely that's exactly I'm going to emulate in these cases which I brought for you. Now going to understanding cervical cancer. Now, this is the latest Globacon 2020, and for both the sexes, the incidences of cervical cancer is amounting to 9.4%. If you take the female cancers, it's accounting to 18.3% of all the female genital cancers. Incidences have increased. Now I'll show you the incidences. In 2018, incidences was 96,000. And look at the Globacon 2020. Now the incidence is 1,23,000. As per the new cases in India, cervical cancer is ranking 3rd after breast and lip and oral. But if you compare for the mortality, it's 2nd ranking. Again, the numbers have increased. It was 60,000, some odd 60,000 in 2018, which has now in 2 years shown a rise to 77,348. Understanding the fact that the cancer cervix, Indian, this thing, we contribute to 20.5% of global incidences of cervical cancer. Again, one very important thing which we have to understand. If you look at the incidences and mortality, there is a difference of 7, and here the difference of mortality is just 2. Why so? Because breast cancers can be picked up little early because of these people are more aware. I have understood in generally people are aware of breast cancers, people are aware of mammography, people whatever symptoms, and it's palpable, you can feel the lump. But what about the cervical cancer? We get these cancers at a later stage when they are coming to us, as what Dr. Vinita was saying, it's stage 3, stage 2B, and it's in that way. And there exactly is where our role as a gynecologist really plays a biggest role, because that's the cancer which can be preventable. And the mortality is low. Look at the mortality. It's really only a difference, a small difference. As I told you, I just showed you these figures. I just quoted these figures for you, 2018, and I told you now 2020. Now where we are at Bihar, let's see. Bihar in 1990 was 44.9 incidences per 1 lakh women, per 100,000 women out over here. What is it in 2016? It's become 53.9 per 100,000 women. So you see, every state has shown a rise, every state. So definitely the onus lies with us. WHO has given a wonderful call of world free of cervical cancer. Is it possible? I've been giving talks, people have asked me to give talks like, is it possible? Is it, why not? It is possible. We all have to join hands. We all have to understand the science well. We all have to know when to refer, what to refer, how to treat. And of course, if we do practice this, I know it is literally, it's overzealous a way of understanding, but why not? Let's give a try. Vaccination, screening coverage, then treatment. So today I'm going to talk, we already had with Bihar and Patna societies and Just now on the 4th of February, we had a wonderful session of SSNPP where most of the Bihar societies had come, where we spoke enough about pre-cancers. We spoke completely about prevention and case management of pre-cancerous conditions. Now, today, we are going to talk about truly cancerous conditions and how do you take it up. And if we do this 90-70-90, then at least the probability is the cancer incidences will be less than 4 per 100,000 women. So that there we are with the cervical cancer control program of primary prevention, secondary prevention of screening and treating the precancerous lesions, tertiary prevention of diagnosing and treating the invasive cancers, and finally is the palliative. God forbid, we do not want to go over here. We do want to stop it right here, and we do not want our sisters and our ladies to come here. So let's see. So there we have with us our esteemed panelists. It's a tumor board mimicking. So dear panelists, I have brought for you one case. This is a 32-year-old case of postcoital bleeding. Now she comes up with a 1 or 2 episodes on and off, and since 6 months, like she's going here and there. All right. And this is her, one of the gynecologists got her screening done. And the screening showed in it, this is actually in April 2021, where the lockdown period was on, in fact. So the screening was done and she came up to be HPV-16 positive and LBC as sketch. She was referred to me in my Delhi clinic, but because of the lockdown, I couldn't travel there. All right. So now she had to wait. I mean, I do not know. She could have gone somewhere else, but of course, the doctor said Dr. Priya would be coming and go to her. What she did was, in the interim time when I could actually fly to Delhi, she got her test done again. Now the patient is doing a test. This is exact case scenarios, what is actually happening with the patients. In July, she again got her pap test and HPV done. I do not know why, but still she got it. And now she's confused. PAP is NILM. Now HPV, of course, is 60. I want to know from Dr. Urvashi, kindly enumerate the significance, like having 16 positive and as sketch. What was the need for her to do another test? Was it a need? How do you take up these cases?
Good evening, everyone. Thank you, Dr.
Yes,
Priya, for making me part of this esteemed panel. So at the outset, I'd like to say that when the first report had come at SH and or HPV-16, either of this report independently mandates a colposcopy. Even if we don't do a co-test, even a SH or HPV-16 mandates a colposcopy, and there was no need for a repeat test. In case if this report was like NILM and PAP is and the HPV-16 positive, then also it mandates a colposcopy, because these are the two exceptional scenarios as per the recent 2019 guidelines, where the risk of cancer is so high that you have to go in for an immediate colposcopy. So we need to understand that for HCL and ASCASH, there is no need to triage, and we have to straight away go for colposcopy. And same way, if it is HPV-16 or 18 positive, no need for triage, we straight away go for a colposcopy.
So that's like when we say, you can even know as sketch, you might, you will agree with me, Dr. Urvashi, as per the ASCP 2019 guidelines, where do you go for an expedited treatment?
Absolutely.
What is the risk factor of getting, the cancers whenever there is an AS sketch and whenever there is an HPV-16? These are put up into 60 to 100%, and where you go for an expedited treatment. So exactly that's where we have to fit in ourselves to understand these things. Dr. Kusum, you're an oncopathologist and you've been seeing multiple cases. Now, this lady was trying to argue with me about her PAP results. Okay, and she was trying to fetch an answer from me. Can you just say, how do I answer this to her? Why is it come as sketch and why is it come as NILM? What exactly is going on?
Yeah, at the outset, I would like to thank Dr. Priya, you, for inviting me. Here, I would first like to know whether both these reports were from the same laboratory or were they from two different labs?
Two different labs.
Okay. So say if I were giving these two reports, like maybe in the month of April, I call it as sketch. And then when another smear comes from the same patient, I give NILM. And if it is brought to my notice, I have given two different reports, what I would do, I would review both the smears and see which report is correct. And if at all I review and I feel that yes, the first report of SH is also right, and the second report of NILM is also right, then my interpretation here would be, my reasoning would be, possibly the second smear which was taken was not adequate. It did not, the swab or whatever did not hit the abnormal area, so the abnormal cells were not picked up in the smear. So they were not seen, not reported by the cytopathologist. That is one. And the other reasoning would be, in the same cervix, there will be areas, like even if say HPV positive 16, there will be areas where some areas would be normal, that is NILM, negative for intraepithelial lesion, and there will be some areas which are either SH or HSIL. So maybe the first time the area which was targeted was the area containing the SH or HSIL, and second time the area was the NILM. So that
So
is
to reduce
possible.
this error, Dr. Kusum, will you want to tell our fellow gynecologists to reduce this error? How do we go about?
Yeah. So no, these are my two reasons. And if at all, say I am a third person and you're saying they have been done from two different labs, then even the cytopathologist expertise comes into picture. Maybe the second smear had abnormal cells which were not seen, not reported by the cytopathologist. So that is a third reason. And if at all it's like different areas, maybe then colposcopic guided biopsy would help, would answer this query.
Precisely. As told by Dr. Urvashi, the best thing is whatever it is, like, PAP, of course, is a very specific test, but HPV 16 itself warrants immediate colposcopic evaluation. There is no two ways on thinking on it. So now I've done colposcopy. When I went to Delhi, my clinic, I've done a colposcopy on her. Dr. Sundari, or an expert colposcopist, will you like to comment on this?
At the outset, Priya, I thank you very much for involving me into this, and Dr. Niba and her team, inviting me for this from the Partners Association. Okay, this looks like as though there is an ectropion here, but see, with the acetic acid green filter, there are a few abnormal vessels I can see here. And this is acetic acid. I think there is a wide, dense acetovite area in sink. And this is again a iodine negative yellow area. You can say this is very typical of elevated dense acetovite area, but it's a wide area. I think a quadrants, if you take from here, this is also acetovite. Quite a bit of cervix is involved in this. And this area, Priya, I have a doubt whether it is overt cancer. Is this the reason why the pap smear will be nil? Because when there is a necrotic cells, is one of the reasons. Dr. Kusum, whether you agree with me or not, many a time we have seen our people will take a pap smear in overt cancer when it is there, and then the pap smear will come nil, and then they send me for the colposcopy because it is looking abnormal. And you say without colposcopy, when I put a speculum, I see it's an overt growth. Then I cancel the colposcopy and take a biopsy and send them off to the referral people. Okay. And could it be that, say, this area, it's a eaten appearance here, typically, plus there are a abnormal vascularity here. So could be it's a overt cancer. And this is the different areas where there is a grades of changes are going on. This is an acetovite area. It already has become overt. Because of that, probably our smear may be nil. I mean, what I experienced in this one, because I get the referrals for colposcopy, this is the way pap smear is nil, and then when you say it's an overt cancer, probably. That's what I feel from this still pictures, Priya.
Yeah. So, as you rightly said, madam, we had seeing a dense acetoviteness. This is the SCJ, but over here again it's like TZ2, and you are seeing a overt lesion, a sort of a necrotic lesion as well. You can see multiple blood vessel patterns, which are truly those abnormal blood vessel patterns, like a comma pattern, waist thread like patterns. This gives you an understanding that this is somewhere going through towards a higher grade lesion, invasive lesion, and a mustard staining. So now I've taken so this is the report which I have given her, and now this is the histopath finding out over here. So Dr. Kusum, we are with you again.
Yeah.
Now I want to understand from you. I had taken a punch, 2-3 punches I had taken. Would have been better, I would have taken a leap for you if I give a session to, a chunk to evaluate. What is the what is your expectation from a gynecologist? How should the chunk be given to you? Many times I see these are necrotic, macerated chunks. And then we expect our oncopathologist to give us the right report. So I want you to, come out with that, like how good a chunk you are expecting from us.
Yeah, before looking at the biopsy, I usually look at the history which is provided. So post speculum findings are very, very important. Like if I get a post speculum finding as unhealthy cervix, erosion, growth, especially when there is a growth, I know this has to be invasive cancer. Unhealthy cervix, again, more likely to be invasive. So that is very important. And yes, when I get biopsy, whatever I need adequate biopsy, adequate tissue, and microscopic, I try to look for underlying stroma. The stroma should be there to see if there is invasion or not. So whenever I get a biopsy, we look at the stratified squamous epithelium, the lining epithelium. We look whether it is showing any dysplasia. And the fact that if it is showing full thickness dysplasia, which tells you this is squamous cell carcinoma in situ, then immediately we go to the underlying stroma and we try to identify the islands of this invasive islands of the tumor cells in that. And if we see that, definitely it is invasive. Many times in post speculum, we get findings something like, it's a necrotic mass. And then we just get though we get a good amount of tissue, but it is only necrosis and inflammation. So in that necrotic, we usually process the entire tissue. In that areas of necrosis, even we can make out whether that necrosis is tumor necrosis is not or not. So we are able to call it as coagulative tumor necrosis. And in that, we try to search for even a single viable atypical cell tells us that this is invasive cancer. So it is quite easy then. But sometimes we receive only the strips of lining epithelium, which is showing, say, full thickness dysplasia. And if we do not see any stroma, then we say this shows full thickness dysplasia, that is squamous cell carcinoma in situ. Underlying stroma is not seen, therefore invasion cannot be commented upon.
Cannot be ruled out or cannot be commented upon. And that's the time when I feel taking up a good a leap session, a leap biopsy would be much better. Otherwise, punches are definitely there. We have taken multiple punch, and this is the report which we have got.
Yeah, many times we even ask for a repeat. Like if it is superficial, we say it is a superficial biopsy. Please give us a repeat deeper biopsy. Sometimes
because
we do
there's
get.
a hairline ambiguity between a CIS. That's where exactly, I take these with a pinch of salt. Like it's a very hairline ambiguity. It's a very hairline difference between a CIS and between an early invasive CA. Correct. And that's the reason why I wanted to bring this case into our focus, that a good biopsy is something which is truly required to come out with this type of thing. Correct. Now, Dr. Sundari, madam, how will you like to proceed? Now, this is the case.
It has come as there is again a doubt whether it is a carcinoma in situ or there is a possibility of squamous cell carcinoma. So probably what we need to do is take a bigger biopsy and make sure that there is an invasion or not. Okay. If there is an invasive cancer, definitely we know we have to do the staging and accordingly we have to treat her according to the stage. Okay. And if it is not invasive, probably we can do a leap. And then if patient is able to come for a regular follow-up, that is important for us. Okay, if she is a person who can come for a follow-up, if it comes as only CIN3, then probably we can do a leap for her. Whenever there's a micro invasion or invasion, especially for this age of this age, probably we need to go for a definitive surgery.
Urvashi, will you like to add up something?
Yeah, as ma'am Dr. Sundari said after we have done a biopsy, we'll definitely need to confirm, because if it is a CIS, she needs a less invasive procedure. But if it is if it comes as invasion, then we'll have to go in for a staging according to the recent staging of 2019, and then treat her whether she needs a type B Kerle-Morrow or a modified radical or a radical hysterectomy, depending on the staging.
So Nikhil, Dr. Nikhil, hi. Now here, which type of imaging modality will you be preferring to stage these diseases?
Yeah, good evening, everybody. Thank you, Priya, for inviting me for this very.
My pleasure, Nikhil. You're from my hometown.
Yes, yes.
So you're very close to me. Please go ahead.
Yeah. And thank you for inviting me for this quite practical kind of a tumor board kind of a meeting. So in this scenario, I think MR is the investigation of choice, and MR is definitely a gold standard, to look at this. Saying this, let us look at the methodologies which are available to image such a procedure. One is ultrasound, the second is CT, and the third is an MRI. But MR, because of its superior resolution, in such a site of this, where a query lesion and a very small lesion, because of its superior resolution, it will definitely show whether there is a lesion or not, if there's a pyramidal extension, if there is involvement of the uterus or the vagina. So MR is the investigation of choice. And the MR we have to do with contrast, plain and a contrast MR. Again, on the basis of MR, there are different types of machines. If all the gynecologists need to be aware that, you have a 1.5 Tesla machine, you have a 3 Tesla machines. So ideally a 1.5 Tesla machine should be enough. There are some open MRs which are, low intensity machines like 0.2 Tesla, something which will not show a very good resolution. But for a 1.5 Tesla MR with a contrast is the ideal methodology to show in such kind of a disease. Now, the other modalities which, you have to see is the other is ultrasound. Ultrasound definitely is a low-cost modality which can show the disease, but ultrasound is again operator dependent, and I will speak on ultrasound a bit later during the course. Now, if we need to compare, usually the gynecologists, they ask for CT scan, or they are more conversant with a CT or a PET CT. But for local staging, the CT resolution is not good enough. Exactly. If it's a very advanced disease, if you need to see the bladder invasion or rectal invasion, then you can go in for a CT scan. But if it's for a very small tumor, then absolutely you cannot see the disease on a CT scan. CT scan or a PET CT is actually used to stage the distant metastasis. If there are, presence of any lung metastasis or liver metastasis or retroperitoneal lymph nodes or bone mets, then a PET CT. So in this case, for a local staging, MRI on a 1.5T machine with contrast is ideal. And if it is proved to be malignant, and if you want to stage it for a distant, then you go for a PET CT. That is a method I want to go for this. Now then other point, the other just one point I want to make is, now for the downstaging of disease, if you treat it with some chemo or something and then you want to compare, usually what is done is the patient comes to us with a CT scan and later on they ask for an MR and then they give us to compare, on MR, just compare with the previous disease. Now it is very difficult for us to compare the CT with an MR. So actually, if you get a MR for local staging and a CT for a distant staging, and if you want to downstage a disease, you compare the local with a local MR for a follow-up. So comparing MR to MR is better than comparing a MR with a CT. So for in this stage, MR
comparison is what we have to really see, not any other two different things. Exactly
Correct.
What you're saying is, Nikhil is right,
Yeah.
because actually patients are doing, and many times we do get CT report and suddenly MR report and we are confused. And so like now, thank you very much, Nikhil. I have with us oncosurgeon. Now, Dr. Rajesh Goswami, hello, hi. So you are with us in the tumor board today. This patient I refer to you. How do you go about with it? Do you want me to refer this case to you, or do you want a gynecologist to do this case? And how will you take up on a downstaging? How do you do this downstaging? Yes, Dr. Rajesh.
Good evening, everyone. First of all, thank you very much to organizer, especially Dr. Vinita Singh ma'am, President of FOX, and Secretary Supriya Jaiswal ji. And thank you very much also Priya Ganesh Kumar ji. Definitely we'd like to have these patients to us. And as said by the radiologist, we will go for MRI in this case. MRI lower abdomen, that is enough investigation, no need for PET scan and other things. Because in case of carcinomas, distant metastasis is very rare, and especially in early cases. But physical examination is also very, very important. And what I saw in this picture of colposcopy, its case is around stage 1A. And by manual examination, PV, PR examination, these are things we should consider, and when we should proceed for the treatment.
So I wanted to know, because this patient was a little confused, okay? She was truly eating my head every now and then because I wasn't at Delhi at that time. I flew back and I couldn't do anything much for her. She said she went to an onco surgeon. All right. Out there, I only told her to go to an onco surgeon and, show it to her. And as you said, she was, 1A2, in fact. Okay. And she was saying, Madam, I have been told surgery, but I do not want to go for surgery. Okay. Is there any option? I want to save my uterus. I do not want to go for surgery. She kept on stressing this fact. So now I want to know from Puneet, who happens to be precision oncologist, who has been giving exact methodology, follow-ups, and everything to the patient. Dr. Puneet, are you there with me? You're there with me? Hi, Puneet. You can unmute yourself, please.
All right. Hi. Now you can hear me. All right.
Yes,
sorry for that. All right. It's a pleasure. Good evening to everyone. And thanks to the President, ma'am, and the Chair Oncology, Dr. Priya, and my fellow panelists. So, and it's been a great session all through. And my take for the gynecologists would be slightly simpler here. And, I'm sure our surgeon colleagues and, would help us, take it forward. I would start from the diagnosis for the cervical cancer is always made with a cervical biopsy. That's how it happens in the real world today here. And based on the lower income, I would say, lower income country, we would say, or partially we are, having different health setups across our country, from center to center, from districts to districts. The things would change. But however, answering this question, we need to understand what's happened in the last 2 years when we talk about the staging and the stuff which has happened in last 2 years. In 2018, we saw the last staging system. And we have to understand for gynecological tumors, the doctors may employ 2 staging systems. The tumor node metastasis staging system is the TNM, which is used by NCCN as well. And the other one is the FIGO system, which we all gynecologists would know by heart by now. The American Joint Committee on Cancer, which is the AJCC, and the International Union Against the Cancer, UICC, have developed a new system now, which is coming in now. The AJCC collaborates with FIGO and UICC collaborates and develops the TNM staging system. After having said so, let's see that the TNM staging includes more detailed information about each staging component as well, which helps us plan the treatment. Additionally, FIGO, if I have to talk about, no offense, the staging updates are inconsistent, whereas the AJCC staging system updates have been released every 5 to 6 years consecutively for last 4 decades. So we have so many things which are being updated. So when I talk about the AJCC 9 system, I would talk about, people can refer to certain studies or we can give them certain tables which are now available online as well, that the 2000 system, how you compare it with the AJCC system with the, TNM staging. So I would say when we are talking about stage 2 here specifically, and stage 2 means the invasion of the cancer is beyond the uterus, but has not extended onto the lower third of the vagina or the pelvic wall. When we talk about the 2A specifically, the involvement is limited to the upper 2/3.
This was precisely in it was not
without
into
the
the
parametrial
2A.
involvement.
Here it is not 2A. Here it was only on the cervix. And
I'm coming to that.
Around
So
1A1.
2A1. Now we talk about the 2A1 is less than 4 centimeters in the greatest dimension, as we all know, right? So when we're talking about this, I would say, there are many modalities one has to look at. And before that, I'm sure my, the friend who is a surgeon would always agree with me that most of the, external iliac metastasis happen like in 43 to 46% of cases would be external iliacs. The obturator metastasis happens in about 26% of the cases. The parametrial metastasis we have to talk about happens in 20% of the cases. Based on this, if we look at, how we plan the treatment, we would say, the TNM staging T2A corresponds to stage 2A of the FIGO. That's where we start. And there are 2 possibilities here. One is for the fertility sparing, and the other is if you don't want a fertility sparing, treatment modality for the patient. When we talk about the stage 1A1, I am specifically talking about with LVSI, and the stage 2A1, which we are talking now, both would be treated absolutely the same way. And in the, so we in this would look at the radical trachelectomy is one option. Pelvic lymphadenectomy is another. Cone biopsies can be taken in case you want to look at it, and followed by pelvic lymphadenectomy, or SLN mapping is very important here. I'm sure the surgeons here would agree with me. And in the
Dr. Rajesh wants to make a point here.
Sure.
Yeah. Actually, in this case, we are confused what is the stage of the disease. So that's why we are getting here and there. So let me summarize. If it is A1A1, then conization is the treatment of choice in childbearing period. If she wants to have a child, conization is the treatment of choice, except if the conization margins are positive or LVSI positive, then she should also go for either sentinel lymph node biopsy or trachelectomy. This is the for 1A1. If it is 1A2, then, and if it is she doesn't want childbearing, then we can do extrafacial hysterectomy, that is type 1 hysterectomy. If it is 1A2 and she wants child, then we have to go for radical trachelectomy, plus if sentinel lymph biopsy facility is available, sentinel lymph biopsy or extraperitoneal pelvic lymph node dissection if the sentinel lymph biopsy facility is not available. And if fertility is not an issue, then modified radical hysterectomy type 2. This should be the treatment.
Very correct, Dr. Rajesh. I wanted to say the same thing. And Dr. Rajesh, I wanted to ask you, if I have to go for a radical trachelectomy, okay, in this case, it is 1A2, and we plan, because we had done a cone biopsy, I had asked for a conization, we had done a conization, and that's how we had done a downstaging, and we came to know that this stage is 1A2. And now if we truly want a trachelectomy to be done, do you think, will you do the first pelvic lymphadenectomy, wait for the reports to come, and then do a radical trachelectomy, or do at the same go and make a frozen section available? How do you practice?
We don't have a facility for sentinel lymph node biopsy in our center. So we usually go for first of all, these cases, when the childbearing age group and trachelectomy and early cases, this is very less in our practice. This is the fact in Bihar, that we usually get cases in stage 2, most of the cases in stage 2. And what we do in this case is that we do it in one setting, trachelectomy and extraperitoneal lymph node dissection.
Do you do a frozen then? At that time, definitely frozen would definitely will be helpful, or how is it like?
No, we go ahead with the surgery.
Okay. So
ideally,
MRI
we should do
over
for
here,
frozen.
MRI
Ideally, but we
definitely
don't have facility for that only.
You don't have facility,
Yeah.
but ideally, if you have a facility, it's one of the
Yes,
best things and truly helps us,
definitely.
because we do have in our centers, we practice oncosurgery with the frozen section, and that really helps us to understand how do you go about.
Yes,
and
definitely.
here I would say that even MRI, why MRI is really precise and clear is, you know exactly that how much to go ahead, to taking a trachelectomy, how much there should be a gap of, I believe Dr. Nikhil, there should be a gap of at least 10 mm between the lesion and the the margins, so that you get a margin free specimen. That's exactly where MRI plays a major role. So this is what I just brought it over here. Ultrasound is being said that these are from imaging modalities. Ultrasound also has been showing good diagnostic accuracy in expert hands. So that's one thing which we have to take it up in a very clear way. And the goal is, in fact, to appropriately understand the method to avoid the dual therapy. Because what exactly goes into the patient's mind is Should I do a surgery? Should I take a primary radiation? So many things goes to the mind, and we as a clinician have to give her an answer and say, see, nowadays primary radiation also is modality of a choice, not a problem. But then what happens with the primary radiation? You're not getting the specimen, and usually you get a satisfaction that you've removed it out, sort of, patient getting a mental satisfaction. Also, you are getting the margin free area, you're getting a histopathological evidences. So normally surgery remains the choice, but people have been talking about primary radiation also, which is also there nowadays in vogue. So for this patient, definitely she went ahead getting a surgery done. And this was a general recommendation, like presence of LVSI. It actually doesn't increase the stage. Normally the staging is done at the first go, and then we follow the stage till the end for the follow-ups, for the regular follow-ups also. LVSI doesn't change the stage. Only thing is it changes the methodology of treatment. And definitely to note that LVSI is very important. And MRI, as we have already said, Nikhil said it very well. And this here we had done her conization. We found her to be this, and this is all we have discussed. So that's the take-home message. And that now take-home message for a routine gynecologist who are practicing, because I believe this forum is basically for the gynecologist of how you practice. Post-coital bleeding has to be taken seriously. Now she was having a post-coital bleeding since 6 months. It was a great thing on a gynecologist who quickly took the smear, looked at the cervix, understood the unhealthiness, and then quickly did all these things. And that's how the patient was detected at the earlier stage. And that's the take-home message from here. Anyone wants to add as a take-home message from this case so that we go to the second case? Any take-home message do you want to give? Dr. Urvashi, Sundari, anyone, all my esteemed panelists?
I'd just like to highlight, ma'am, here that as you said, we should always treat the patient and not the report. Like I had a patient of post-coital bleeding who just, like Dr. Sundari ma'am highlighted, sometimes because of necrosis and all, her PAP was inconclusive and was even reported NILM, but her post-coital bleeding persisted. So I went ahead and did a colposcopy and a biopsy, and it came out as carcinoma. So we should always not ignore the patient's complaint, and we should always remember that dictum that treat the patient and not the report. Even if the report comes as NILM and the complaints are persisting, we have to give due cognizance to that.
And another thing, as the ASSCP 2019 guidelines says, the risk stratification, post-coital bleeding, post-menopausal spotting, bleeding has to be taken up seriously and has to be evaluated with colposcopy. And you need not even wait for the screen positivity. Even those days have gone when we used to say colposcopy indication, screen positives go for colposcopy. But now the symptoms are given a lot of importance. Histopath is given a lot of importance. And that's how, now let's go to the second case. Even this is a wonderful case. Now I've got a case for you who's a menopausal. All right. So this is another risk stratification case of post-menopausal spotting, 56 years old. She has got her menopause. She has achieved her menopause 8 to 10 years back. She has undergone colposcopy with biopsy. So over to you, Dr. Madam, Sundari Madam. This is her colposcopy.
No, this is an ulceration. I don't know. This is, I think, a light reflection everywhere.
These are the light reflections which has come up.
And light reflection is coming up. Apart from that, I'm not able to see. This may be a white patch. I'm not very sure in this because the picture is not very clear.
This is completely an ulcerative sessions.
I'm not able to see. Here, this may be an alteration because the denudation of the superficial epithelium is seen here. This well see, but here this is the light reflection, and underneath that, is this an aceto-white area?
This is a complete dark aceto-white, dense, chalky aceto-white area.
Aceto-white area, which is extending into the canal, is it not? The extension is into the canal, it is.
Plus also, madam, can you appreciate, I do not know, here we do have a breaking mosaics.
Yes.
Relevance of a breaking mosaics are
here probably this picture shows well, Priya.
Yes, madam. See over here also, you can see.
Yes, and from anterior lip, it is going into the canal also, extending into the canal here. Okay, and wide extensive area of aceto-white with an ulceration here on the posterior lip. That's what I feel.
And the signs are also positive. RAG signs have now been picked up. And what is RAG sign? Because people have been asking me these questions. This is for the local, gynecologists who have interest in colposcopy also. So the RAG sign, ridge sign, see over here, these are the ridge signs.
Yes.
Where you have valleys and then you have those, ridges. A rag is what? It's like, the ulcerative portion just coming out like a rag, like those, thin cotton wires, coming out. So it's a rag sign here. And you can see these are the breaking mosaics. A breaking mosaic gives you an understanding of invasive, micro-invasive or invasive CA. So this type of, it need not be a tumor coming out. Basically, what I want to get is a colposcopist should be in a position to interpret these and find out the results. You cannot miss it out. Always a tumor, it's very easy to understand a tumor, You take a biopsy and you got it. But a colposcopist has to see into all these things to come up with it. We have done a biopsy and this is the report. So it's a large cell keratinizing squamous cell carcinoma of the cervix. Madam Kusum, we want to know from you, are there some changes which has occurred in WHO for classification of, this thing, histopathological classification?
Excuse me, madam, sorry to interrupt. Because the organizers have just said that it's 8 minutes left. So
we will be able to finish it.
8 minutes to be precise.
Yeah, we will be very much, 8 minutes is more than enough for us. Thank you very much, Niba. So Dr. Kusum?
Yeah, I would just like to say, this is the WHO classification and the report has been keratinizing. And when we give this HP report of keratinizing, you should understand that the studies have shown that these keratinizing squamous carcinomas do not respond so well to radiotherapy as compared to non-keratinizing and other CAs. And based on this different HP types, histopathology types, like, there are different prognostic, they have different prognostic parameters. Like, as I said, adenocarcinomas, the 5-year survival rate is almost similar to the squamous cell carcinoma stage by stage. Then there is something like adenoid basal carcinoma, which has a very good prognosis compared to adenoid cystic carcinoma of the cervix. Then coming to mucinous adenocarcinomas, amongst this, we have gastric mucinous carcinoma, which has a very bad prognosis as compared to the usual endocervical type adenocarcinoma and the usual intestinal type of adenocarcinomas. So these different histopathologic types have different prognostic parameters. That's what I would just want to say.
HPV associated ones have now become in vogue, where HPV associated and HPV independent. And I believe that HPV associated ones have a better prognosis than an HPV independent one. And hence that's the precise reason you should know her HPV status, even to give a prognostic, a diagnosis or a prognosis to the patient. So Urvashi, there has been a little bit of a differences in FIGO, which, even now Puneet said that there has been a little changes. So quickly, because of the lack of time, can you quickly just go about with this FIGO classification, and what is the addendum now, which is added?
So in 2018, we had this classification, which was the addendum was issued in 2019. So we have three major changes. First is now the horizontal spread is done away with because it doesn't affect survival. So now we don't have that 7 mm thing. The second one was that 1B is now divided into 3 stages. So 2 centimeter, which is equivalent to 2 centimeter, is now 1B1. In 2018, it was 1B2. So then now they have made 2 and 4. Up to 2 is 1B1 and up to 4 is 1B2 and more than 4 is 1B3. The third change is if there's lymph node involvement, micrometastasis, or involvement, macrometastasis, that comes in stage 3C. And few things which are not included. First, LVSI is not alter the stage, but affects the treatment. Second, extension to the body doesn't affect the stage. Third, the extension to the ovaries has not been included in this staging. And fourth is isolated tumor cells have not been assigned a stage. Only micrometastases have been included, which are in 3C. The second paradigm change which happened was that now the FIGO has allowed us to use all imaging modalities, MRI, PET CT, CT, ultrasound, to allot the stage. What all can we see with these modalities? We can assess the tumor volume. We can assess the spread and we can assess the lymph node status. And if they are radiologically involved lymph nodes, we put a notation of small r in the bracket. And if they're pathologically proven, then we put small p. So they are real help to the clinician, and now we can, stage them in much better way and treat them.
And this goes in, they have, it goes in tune with their TNM as well. They have now taken up, somewhat similar. So the FIGO staging has really taken a toll. Now this patient is from, Karnal, that is interiors of Sholapur. No, so Dr. Nikhil, any role of, there is no MRI out there.
Yes.
Any role of sonography?
Yeah, so as said earlier, MR is the gold standard, but MR is not available, especially in the rural states. And also, as I told you, that MR should be at least a 1.5 Tesla MR. Even if the open MR or low Tesla MR resolution will not be better. So in this scenario, ultrasound definitely offers as a a cheap or a cost-effective alternative. And given between the CT and an sonology, sonography is definitely better for local staging of the lesion rather than a CT scan. Having said that, there are some limitations for ultrasound. That is, it is operator dependent as well as technique dependent. As we said, as in technique dependent, it will be transabdominal sonography, transvaginal, and there's something called the transrectal ultrasound also, which is not become so conversant. In transabdominal, we have the the abdominal fat, which can be prohibitive in looking at the lesion, or there may be bowel artifacts. In this, you have to fill up the bladder, which can act as an acoustic window to see the cervix. And in transabdominal ultrasound, rather than that, if we do a transvaginal ultrasound, you can take the probe near to the area of interest and it will give a good resolution. But only thing is, the lesion is small. If the lesion is quite large, then it will be painful or there'll be bleeding when you do a transvaginal ultrasound. As apart from transvaginal, you could do a transrectal ultrasound. It was one of my thesis when we did in Tata Memorial Hospital, when a transrectal ultrasound was done to evaluate the CA cervix. But only thing, it has not taken up well, because you require expertise to see the transrectal ultrasound and to see the cervix, because there are some orientation problems and all, and you require the special kind of probes to do the transrectal ultrasound. But if the transrectal ultrasound is done properly, then it has got the same the results as that of an MRI. So definitely sonography has a role, transabdominal, transvaginal, or a transrectal, to look at as good as MRI, and it is a low cost alternative to MRI, especially in rural India.
Yeah. So this gives our understanding that yes, sonography is there to stay with an expert hand and do it in a proper fashion.
Yes, sure.
Now, other investigations, Dr. Sundari, can you quickly come up with? Because of the lack of time, we are just
Other
going
investigations
fast.
are routine investigations for a surgery, patient evaluation, the blood investigation, CP, and then the renal function, liver function test, X-ray chest. And then if she has any other problem, she's only, how old is it? Maybe an ECG, because we take up surgery. Even if for the radiotherapy also, we need to do the basic investigations to keep line with the CBC, renal function, liver function test. That's a minimum.
Rectum also, if that is clinically
and then if
symptomatic.
Routinely it used to be the cystoscopy and all. In Kidwai also, they used to do every carcinoma cervix patient cystoscopy routinely, but I think we don't do now routinely unless we have, because MRI is there. If there is a plane, fat planes have been obliterated between the rectum and the uterus, or bladder and the uterus, then probably they go for the cystoscopy or proctoscopy. Otherwise, those things are not done routinely.
Because now we have an MRI which we can understand this things. Now, Dr. Goswami, what do you mean by downstaging? This is one thing which people keep on asking. Why do a downstaging? Number one. And again, in these cases, like, what are the different types of hysterectomy? We can just quickly go through it because we don't have to be in detail, because this is a forum of not oncosurgeons or this is a normal gynecologist joining us. So, and also enumerate on fertility sparing surgeries, what we can do. You had done that in the first case, so we can. Now, what I want to mainly highlight is what is a LAC trial, and now so much of a fashion for endoscopy. So all that thing I want you all to, to please come up with.
Due to lack of time, I will start with the LACC trial, which is like an earthquake or a bombshell or explosion, whatever you call. It came in 2018 and published by MD Anderson Institute, USA. It was a large randomized trial involving different centers in the world. And the highlight of this trial was it compared the laparoscopic, robotic versus open surgery. And it clearly said that the result is inferior in minimal access surgery arm than the open surgery, and result is so obvious that it is more than 10% local recurrence and more the overall survival also inferior. So it is kind of really shocking to everyone, because in many ways minimal access surgery were very helpful to the patients, but I myself was also trained in this minimal access surgery, and it takes very long time to learn another thing. There are some criticism to also LACC trial, but the result is so convincing that most of the center in USA, UK, and European center, they have stopped doing cases with minimal access surgery, particularly carcinoma cervix cases, and they have started doing open surgery. We are just waiting for some other new trial to come and disprove this trial, which is, I think it is very difficult, because it was a large randomized trial. So for the time being, we should also inform, if we are still doing minimal access surgery, we must inform the patient about this trial, and then only we do surgery with a minimal access, either it is laparoscopic or in a robotic way.
So open is much preferable.
Yes,
and
definitely.
that's one thing which is a take-home message, that we better, not for the fashion, but it is definitely open is much preferable. We have a overall survival rate is high, and disease-free interval is also high. And what we have in a FIGO staging 1B1, 1B2, and 2A1, they're all similar. Normally we go for type C radical hysterectomy. That's what we have been doing. Now the staging, what Urvashi said it very correctly, no, less than 2 centimeter. Why that came up as less than 2 centimeter? Because the pelvic node involvement has been really less. That's what the study is. That's why they came up with the 2 to 4 and above 4. Now above 4 and all is more like a above 4 and all, definitely there will be pelvic involvement, and hence their CCRT really helps, rather than, so when we have 1B3, it is similar to the sort of 2B and all that. So when we then talk about directly with directly primary radiation rather than surgery, or we can do a CCRT outage. So here we have types of radical surgery. We are all we know about it. We have been doing it. And LVSI, truly, whenever there is an LVSI, we go for modified radical hysterectomy. That's the main thing. Now, Dr. Puneet, there has been what do you mean by locally advanced cervical cancers? Because people have been talking about that also very commonly. So I want you to enumerate on the role of locally advanced cervical cancers. What is the role of radiation in LACC? Kindly explain EBRT, IBRT very quickly, and PORT trial. Now, PORT also is a post-operative radiotherapy trials. Do you suggest neoadjuvant? All these questions are now to you. A basket of questions.
I'll just go to the main points and not cover the basics here. LACC is the abbreviated form of that. We cover the cancers which are from the that is 1B3, stage 2, right up to stage 3 and a 4A, for which we will put them into the LACC category of the staging. And now when we talk about the role of the radiation therapy, we have radiation therapy may benefit patients with earlier, which is like the stage 1B to 2B, and maybe advanced stages, which is 3 and 4A. And I'm not going into the palliative, which may be also a part of it. One has to keep in mind what are the side effects and the curative powers of the radiation surgery therapy before we go into that, as palliative may be one option which we have discussed. Now we have something which is, people talk about what is an EBRT and the IBRT. I as an internal, and I would say E as an external, radiation therapy. That's how one should look at. But before planning to do this, some patients may have, like I said, the RT-related toxicity, which is IBDs, and maybe diabetes and hypertension. Hypertension have to be kept in mind before we plan. RT, we have to understand, is directly or directed at the sites, whereas, where we feel there's a suspected tumor involvement beyond whatever is removed by the surgery. And EBRT is directed to the pelvis, with or without the para-aortic region. That is what is the difference between the EBRT and the normal, definitive RT. Talking about brachytherapy is, I would say brachytherapy is something which we call as the internal radiation therapy. So that's another name I'd like to introduce. So we have to be mindful about EBRT and the brachytherapy. And in fact, the brachytherapy is a part of the EBRT. Now, there's another, let's say a terminology called as the port. Now, this port for medical oncologists would mean a chemo port. It is not like a chemo port, but we have a radiation port. Now, radiation port is, which is, something which can be, perplexing or it can be confusing. But the radiation port, you have to understand, it's not a device, but it's rather a term that refers to the area of the body where the external beam radiation will be directed in order to reach your tumor or the region where you're looking, or the surgery was performed. Whereas another is port has been introduced by the Indian, I would say leads and faculties also, which is post operative radiation therapy that has been talked about in the GOG 109 trials as well. So post or the intraoperative theory radiation therapy has been also been talked about in the NCCN guidelines, I would say, and one has to look at where all these can be used. When we talk about the radiation therapy and the adjuvant RT, so adjuvant RT is usually administered to women if the intermediated staging has been done and the risk factors were identified, and at the final pathological analysis of the uterine specimens. Risk is based on, in fact, the lymphovascular space invasion and depth of the cervical stromal involvement and the tumor size. So adjuvant chemoradiation is nothing but, another word is CCRT for this, which is concomitant chemotherapy plus the RT. So which is usually administered to the women following the primary surgery, and there is evidence of the positive surgical margins that we have already talked about. Pathological involvement of the lymph nodes is present, or an invasion into the parametrial tissue. Now we are also talking about certain terms in, what are the doses? I'll quickly talk about. Doses would vary for the port and the EBRTs and so on. EBRTs have various other modalities called the low dose radiation, or the rates as we call them, the pulse dose rate, or the high HDR system, which is a high dose rate system as well. So the GY is the grays. So we give like 40 to 50 grays usually for all patients. And I'll not go into the details of the LDR specifically and the cycles, how many of them. But I would say there was a question also on the Q&A on the neoadjuvant therapy, and which is with the chemos and the chemoradiations. I would stand out of that, and I would say that it does not really matter. So because the neoadjuvant chemotherapy we talk about is prior to the definitive hysterectomy or a surgery which you are planning on the patient, and does not offer an overall survival in all studies, all across different types of modalities, and the advantage related to primary chemoradiation is also very low. So any questions on that I can answer, and I think that's all.
Yeah, so you have answered everything. I mean, precisely what we as a gynecologist should be knowing, and how we should be going. So thank you very much. And we close our panel here. Thank you very much, all the panelists, to really throw lights on each and every aspect which a gynecologist should know.
15 seconds. I'm apologies. I was just talking about one of the Outback trial which has come up very recently. That is a very important thing. Forgive me for doing that, but then the Outback trial is, we nowadays call in medical oncology, is the backout trial, right? Wherein we have thrown out that they have about 1,000 women were taken, and it was found that no survival benefit was found with adjuvant chemotherapy after the standard chemoradiation for LACCs. So maybe the times are changing, and we have to look at some other treatment down, because 5 years data which did not come up well, and I think the treatment modalities have to change. So that's the Outback trial. Over to you. I'm sorry about that.
Thank you very much. So we come to the end of this panel discussion session, and thank you, Dr. Urvashi, Dr. Sundari, Dr. Nikhil Kamath, Dr. Rajesh, Dr. Kusum Jashnani, Dr. Puneet, and you all have really clarified various things. We have now talked about all the aspects of treating a cervical cancer. What a gynecologist should know, and how we should be proceeding. Over to you, Dr. Niba.
Thank you so much, Dr. Priya, for this wonderful session. And you moderated it so wonderfully. And I think audience must have got very clear message about their level, what they have to do at the early stage, what screening, referral, management, everything. And sorry that we interrupted you in between, and that is our loss that we cut short your session. What I think you must have expanded it much more, but it's okay.
It's okay. We could cover up everything in this time. So thank you very much.
So thank you, Dr. Priya, for everything. And thank you all the panelists, Dr. Urvashi, Dr. Nikhil, Dr. Rajesh, Dr. Sundari, Dr. Puneet, and Dr. Kusum. Thank you all for your wonderful
Thank you very much.
Thank you very much for inviting us.
Thank you very much.
Thank you. So that's the end of the scientific session. So at the end, I request our secretary, Dr. Supriya Jaswal, to propose vote of thanks. Dr. Supriya, a very active and dynamic young secretary of our society. And she is really working hard for keeping us updated with all the webinars and many educational activities. So over to you, Dr. Supriya. Please propose vote of thanks for everyone.
Yeah, thank you, Nibhati. So Thanksgiving is always very nice feeling. I take the privilege to thank the chief guest of today, ICOG chairman, that Dr. Uday Thanawala sir, and the Foxy office bearers, President Foxy, Dr. Shanta Kumari madam, Secretary General Dr. Madhuri Patel, Dr. Archana Verma, Vice President Foxy, and the guest of honor of today. She is also in charge of this oncology committee, Foxy. Dr. Uday Thanawala sir, who has been the chief guest of today's program, Dr. Priya Ganesh Kumar, who is the person behind the whole show, the chairperson Gynecology Oncology Committee of Foxy, and the moderator of this great panel. So, and very wonderful selection of your panelists, madam. Thank you very much for the wonderful session you had just now. So, and the brilliant speakers, Dr. Vinota Thomas, Dr. Bindya Gupta, who crisp and clear messages given to all the viewers. Esteemed chairpersons, Dr. Renu Rohatgi, Madam, Dr. Rekha Jha, Dr. Sangeeta Pangaj, Dr. Rita Sinha, Dr. Abharani Sinha, and Dr. Vinita Trivedi for sharing the session with full of interactions. The learned panelist, the moderator I already mentioned, she was wonderful. All the case discussion, everything was very, very nice. And the learned panelists, Dr. Urvashi, Dr. Sundari, Dr. Kusum Jashnani, Dr. Nikhil Kamath, Dr. Rajesh Goswami, who in spite of his busy routine, Dr. Rajesh, thank you for coming. Dr. Puneet Chandana, and all the panelists. Thank you to all the viewers and from all the societies who had logged in. So we had a good number of viewers, more than 130 plus right now. And so lastly, we'll thank our pharma partners who really helped us so much with the background of Mr. Shield Pharmaceuticals, Chitrakala and Suman. And actually, what to thank our own office bearers, the President, Dr. Vinita Singh, Vice President, Dr. Pragya, she sent her apologies. Dr. Meena Saman, Dr. K. Manju, Dr. Nibha Mohan, Dr. Anjana Sinha, Dr. Amita Sinha, all were there, and I really thank everyone, all my seniors and everyone. Thank you from core of my heart.
Thank you, Dr. Vinita, Dr. Supriya, and everyone to log in. Thank you very much.
Dr. Priya, there was one question. Actually, Dr. Anita is asking that which one is better for screening, the conventional method or the LBC method? For screening,
both are good. If you have to see an HSIL, there are sensitivities the same, but when it have to be in L-cell cases, no, the sensitivity improves with LBC because the inflammatory thing goes away.
Yes.
So LBC is definitely a proven good method for screening.
Thank you.
Thank you very much.
Thank you.
Thank you. Good night.
Thank you, everyone.
Thank you, Doctor.
Thank you.
You can end the meeting.
Thank you, Mom.
Thank you very much. Thank you, Nibhati.